Warmly welcome, everyone, to the Department of Psychology at Stockholm University. My name is Torun Lindholm. I'm a professor in social psychology, and I will be the chair for this dissertation session today. Today, Cherniak will defend his doctoral thesis, and the thesis has the title Relationally Informed Psychedelic Science, Conceptual Framework and Empirical Studies. There are extra copies over there if anyone is needed. So one of the main persons here today is, of course, Aron. So a special welcome to you, Aron. The other major actor is the opponent. I warmly welcome Professor Michiel van Elk from Leiden University in the Netherlands. And then we have 4 additional important persons here, the examination committee. From the Department of Neurobiology, Care Sciences and Society, we have at Karolinska Institute, we have Professor Walter Osika. And from the Department of Clinical Sciences at Umeå University, we have Professor Eva Hemje. Associate Professor Emanuela Gripeo. From the Department of Ethnology, History of Religions and Gender Studies here at Stockholm University. And we have our in-house committee member, Associate Professor Robert Johansson. And Aron's main supervisor has been Professor Per Granqvist from this department. He's sitting here. He's responsible for everything. And we also, Aron has also had a co-supervisor, Professor Mario Mikulincer at Hebrew University in Israel. So I will say a few words now how this dissertation session will proceed. So Aron will first will summarize his thesis. Yes, I had some discussions with Per. How was?
I think we'll do Michiel first and then Aron. Michiel first, I think, and then Aron.
Okay, I thought you said Per. Okay, so that's right. Michiel will give an overview of the field. Connected to Aron's work, and then Aron will summarize the thesis, and then we have the part of this session that everyone look forward to, namely that there will be questions from the opponent to Aron, and we look forward to a very interesting discussion about this fascinating topic. Thereafter, when Michiel feels that you have said everything you asked Aron, everything you need, then we have the examination committee who will have the chance to ask Aron questions. And finally, the audience, the floor is open for you in the final stage to ask any questions that you have always wanted to know from Aron's work. Yes. Before letting Professor Michiel van Elk start, I want to ask Aron if you have any errata in the printed version that you...
Not that I've seen.
Okay,
yet.
okay. And it's nothing big, nothing.
Yes, but I have reviewed it.
Yeah. All right. So then the floor is yours, Michiel, Professor van Elk.
Thank you. Good morning, everyone, and thanks for the invitation. I'm happy to be part of this and looking forward indeed to the defense as well. I'll try to provide a short introduction to the topic of today, psychedelic therapy. And the title of the presentation is A Sober Look at Psychedelics. Because many people have these stereotypical associations with psychedelics. These are substances like LSD or psilocybin, which is the active ingredient in magic mushrooms that make you crazy, make you hallucinate.
The microphone?
I can use the mic.
You take, I think, one over there if you want.
Or maybe one of the headsets.
The headsets.
That one's ready. That one's ready.
Good if you
I think that's unload. Actually, there's no battery in there. So do you want to take this one? Yes, that should be working. Do you understand?
Yeah.
Yes.
Okay.
And then I will just turn it on and on.
Yeah, thank you. Okay. Hope that works better. So the typical associations that many people have without any background in psychedelics is that those are substances that induce effects like we know from movies like Fear and Loathing in Las Vegas. The floors start to move, the walls start to breathe. Many people think about the 1960s, the counterculture, Timothy Leary giving LSD to his students. But these days we see a renewed interest in psychedelics in our society. So many people visit, for instance, a psychedelic retreat where they take psilocybin or ayahuasca for many different reasons, self-exploration, spiritual development, etc. And these retreat centers are in the Netherlands, for instance, legal, or many people travel to South America to visit these retreats. And the topic of psychedelics has also been popularized by Michael Pollan, who has written the book How to Broaden Your Mind, and also featured in the Netflix series on psychedelics, where he points out the interesting science that is going on psychedelic therapy and on the neuroscience of psychedelics. And in contrast to what many people think that psychedelics do, is that they don't drive people crazy, they don't only induce hallucinations, but he and many other people point out that psychedelics have the potential to trigger quite meaningful and profound mystical experiences that can be life-changing and that can be very important for people in the same category of impact as having experiencing the birth of your first child or the loss of a loved one, major life events that put everything in a different perspective. And as a consequence of this impact, many people are also more and more interested in applying psychedelic therapy for different kind of indications. Because of these mystical experiences, they see potential for psychedelics for treating depression and anxiety, for instance. So what I would like to do in the next 15 minutes or so is shortly provide an overview of the state of the art of the field. What are psychedelics? What are we actually talking about? What are the applications that we see in practice? What are the mechanisms of action? And some concluding remarks. Where is the field going? So if we talk about psychedelics, this typically refers to a broad class of different substances. And a distinction that is often made is between the so-called dissociatives, such as ketamine, entectogens, including ecstasy or MDMA, and classical psychedelics, including mescaline, LSD, DMT, and psilocybin. So the nomenclature is a bit confusing. We talk about psychedelics to refer to this broad class of different substances, and classical psychedelics is typically used for the serotonergic psychedelics. And all these different groups of substances have different subjective effects and also different clinical applications. So I'll shortly explain each of these substances. So ketamine is an NMDA antagonist. It is developed initially as a dissociative anesthetic, and it is still used as such. But at higher doses, people report also feelings of floating, derealization, depersonalization, out-of-body experiences, and at an extremely high dose, even a K-hole, basically a void where people can end up in. And in the US, but also increasingly in Europe, we see commercial ketamine clinics offering ketamine treatment for people who need it and who are seeking this out. MDMA is a so-called entectogen. It works primarily by triggering the release of serotonin, and its subjective effects include increased energy, empathy, enhanced communication, intimacy, and enhanced sensory perception. It is often well known as a street drug and used at parties and in the rave scene, but it's also increasingly used in clinical applications, particularly for the treatment of PTSD. Classical psychedelics. This is typically what we refer to when we talk about, for instance, LSD or psilocybin. The active ingredient in magic truffles and mushrooms, but also mescaline from the peyote cactus or DMT, the active compounds in ayahuasca, are all examples of classical psychedelics. And you can see that the basic structure of classical psychedelics resembles the serotonin molecule in the brain. And it's also known that these substances act by binding to the serotonin receptor, the 5-HT2A receptor. And by doing so, they trigger the subjective effects associated with classical psychedelics that include eyes closed hallucinations. So it's not the case that people start hallucinating as if they're having psychosis. It's more that they see things with their eyes closed, and with the eyes open, sensory perception is altered. Synesthetic experiences, the blending of the senses, altered space and time perception, feelings of a magical reality, mystical experiences, and ego dissolution at higher doses are typically reported. So we have three groups of psychedelics: the dissociatives, entectogens, and the classical psychedelics. What are the clinical applications that are being investigated? Well, first off, there's a lot of research on microdosing psychedelics, where people take a tiny amount of a psychedelic substance, and they do so for many different reasons: improving mood, decreasing anxiety, enhanced creativity, cognitive enhancement, better focus and attention, increased sociability, physical complaints, for instance, cluster headache. And all these different applications are also currently being investigated in controlled trials. The evidence for the efficacy is rather mixed. There are a lot of cross-sectional studies reporting users who microdose versus don't microdose, and those studies typically find positive effects. However, those effects can be explained by placebo effects, expectancy effects, motivation, etc. And then on the other end, you have the placebo-controlled studies, and there the findings are a bit all over the place. And there's not very strong evidence that microdosing is really effective for depression or cognition or executive functions. If we then focus on clinical applications of the different groups of psychedelics that I just introduced, we can see that dissociatives, and particularly ketamine, is primarily used for the treatment of treatment-resistant depression. It is approved by the FDA and the EMA in 2019, and as such, it is available for psychiatrists to prescribe to patients. The effects are short-lasting, so people improve for a couple of days, but then they need another dose of ketamine to maintain the antidepressant effect. MDMA is currently not legal, but is investigated within the context of clinical trials for primarily post-traumatic stress disorder. So phase 3 trials have been conducted, but the FDA rejected MDMA-assisted therapy last year because they argued that more research is needed to establish safety and efficacy. Classical psychedelics is basically the group that currently receives most attention because it also has the broadest range of applicability. Current trials focus on depression, end-of-life anxiety, addiction, but also obsessive-compulsive disorder, anxiety, and so on. So a wide range of potential applications. And that also triggers the question, how can it be that one group of substances has such a broad range of applicability? And in order to get a better understanding in this, it is interesting to focus on mechanisms of action. Because the classical psychedelics work at many different levels, and all those levels potentially help to explain why a single group of substances could have such a wide range of applicability, because they act at the pharmacological level, the neural level, and the psychological level. And each of those levels might explain why, for instance, people who are depressed improve in their well-being. Very shortly, the pharmacological level. We've seen already that classical psychedelics resemble serotonin, and they act on the 5-HT-A receptor in the brain. You see here receptor density maps. You can see that 5-HT-A receptors are quite dense in, for instance, medial prefrontal regions, which are associated with high-level cognition, thinking about the self, rumination. Next to that, it is also known that classical psychedelics trigger something that is known as neuroplasticity. So by binding to the 5-HT-A receptor, they trigger a process that can be characterized as neurogenesis, dendritogenesis, and synaptogenesis. So making new neurons, synaptic connections, and dendrites. So increasing the complexity of neurons in the brain. And they do so by triggering intercellular processes that are characterized here, for instance. So they bind to the 5-HT-A receptor. This results in increased glutamate signaling. This triggers the NMDA receptor. And that in turn results in the increase in BDNF, brain-derived neurotrophic factor. And this might well underlie changes that have been observed in neuroplasticity. So here you see on the left side versus the right side that there's an increase in neuroplasticity triggered by these intracellular processes. And this might be one mechanism, because depression is characterized by reduced neuroplasticity, for instance, and psychedelics seem to be able to restore this to a certain extent. By doing so, it has also been shown that psychedelics can reopen critical windows of learning. So this is research mainly based in animals, where animals are conditioned to learn one area with reward and one area without reward. After a certain age, the animals are no longer able to learn that association because the critical window has closed. What this study has found is that psychedelics seem to be able to reopen this window of plasticity. And different psychedelic substances, such as ketamine versus psilocybin versus LSD, seem to have different effects on the reopening of the window. So after LSD, the animal becomes more flexible to learn new associations up to 3 weeks. With ketamine, the effect is rather short-lasting. So this might be another therapeutic mechanism that psychedelics trigger plasticity and thereby might restore the opportunity to learn new positive associations. The third mechanism is anti-inflammation. It is known that psychedelics can also reduce inflammatory processes in the brain and in the body. And also inflammation is a hallmark of psychopathology, and psychedelics seem to be able to suppress inflammation. Well, at the neural level, a very profound model that has been proposed to account for the therapeutic effects of psychedelics is the rebus model. And this model basically states that the brain works like a prediction machine. We predict the world continuously. And what psychedelics do is they inhibit the predictions. So they basically break the prediction machine. So this is the brain in the normal state, and this is the brain in the psychedelic state, reduced predictions. And that has been proposed to account for well-known phenomena of psychedelics, such as, for instance, visual trails. Normally, I predict the trajectory of my hand through my visual field. Psychedelics disrupts this process, and I see a pattern of trails instead. Or normally, my brain predicts that the floor is solid, that the walls are solid. Psychedelics suppresses this high-level knowledge, and thereby it might seem as if the walls become an organic object and start to move instead. And the therapeutic implication of this is that normally we are rigid in our behavior and thinking, especially people who are depressed, anxious, addicted. They are characterized by rigidity, always taking the same route when they descend the skiing slope, so to say. And the metaphor that has been used to explain the effects of psychedelics is that they liberate the brain. And this is a well-known figure to illustrate that. They make the brain more malleable, and that allows skiing different pathways. And that might be a potential mechanism explaining why psychedelics could help people who are depressed, because they basically expand the action repertoire and belief repertoire of people. Then finally, the psychological level. Psychedelics do a lot at the experiential level, and that could also explain why they are therapeutically effective. So, for instance, it is well known that they can trigger mystical experiences, as demonstrated by Panke's Good Friday experiment. Mystical experiences have a profound and lasting personal significance. And Roland Griffiths from Johns Hopkins University was also one of the first people to point out the life-changing effects of these mystical experiences triggered through psychedelics. Next to that, they can trigger feelings of awe. People can just be overwhelmed by the beauty of the visuals they see or the synesthetic effects they see. And this can also be therapeutically relevant because people might put their life in a different perspective, might realize there's beauty after all, might update their schemes. It triggers a need for accommodation, changing your mental models in light of what you just experienced. A third psychological mechanism. Psychedelics work as non-specific amplifiers, and as such can be a microscope for therapy. They amplify everything that is already present in a person, but they bring it to the surface. They bring unconscious content to the surface and make the deep unconscious dynamics available for conscious processing. And that can also be therapeutically relevant. So people who are depressed might feel extremely lonely, extremely sad in the moment, but in the end, that experience, which is challenging, can be therapeutically meaningful. And interestingly, psychedelics can also trigger supernatural encounters. Many people report the feeling that they meet with ultimate reality, or that they meet with other entities from different worlds, or that they get communication or messages from beyond. And also those encounters can be therapeutically meaningful, having the feeling that you receive advice or consolation from the other side, for instance. So all those mechanisms jointly explain probably why psychedelics could have such a broad range of clinical applicability. However, before my final concluding remarks, a topic I talked about more extensively yesterday are the methodological problems underlying this research. Because this might seem like a very nice picture, all the promises about therapy, mechanisms of action. However, for each of these findings, it is important to be aware that there's a whole list of methodological confounds underlying this research, including selective reporting, small sample sizes, lack of appropriate control conditions, selection bias, breaking blind, adverse effects, placebo effects, lack of durable effects or remission of patients, researcher bias, therapist bias, unclear mechanisms of action, and the nice figure I showed you can be debunked actually if you more closely zoom in on the neuroscience of psychedelics, and conflict of interest. And together, these problems basically put any claim about the efficacy or safety of psychedelic therapy in jeopardy. So currently, it is too early to conclude that psychedelics can be used for treating depression or anxiety. We need more rigorous evidence for that. And that is currently being collected in phase 3 trials, for instance. So we need more and better research to establish safety and efficacy. We need better insight in mechanisms of action, and the thesis of Aaron also speaks to this issue. Psychedelics are not a magic bullet, even though many people often are inclined to believe, based on what they see in the media and in Netflix series, that psychedelics can cure anything. It's not as simple as that. We need more attention to the therapy component of psychedelic-assisted therapy. In the current discourse, there's a lot of emphasis on just the molecule itself rather than the therapy. And we need better insight in what works for whom. Psychedelics could maybe help people who are depressed, but not everyone. And we need to find out what type of depression or anxiety might benefit specifically from treatment with psychedelics. So with that, I hope I've presented a bird's eye view of the field. And I would now like to give the floor to Aaron for zooming in more deeply on the work that you did for your thesis.
Hi, everybody. Thank you all for coming. Before I begin, I'd like to thank both of my supervisors, Per Granqvist and Michiel, for all the time and energy they invested in me. Thank you to the reviewers and the grading committee, and to Michiel. It's a pleasure to hear you address these topics. And also to thank my family and friends whose support I've had throughout my PhD, including my mother who's come from Canada to join us. Okay. Psychedelic research is still in its early stages. New studies emerge constantly, yet the field lacks cohesive explanatory frameworks. Some fall into a psychedelic exceptionalism, treating it as a standalone discipline that must reinvent the wheel rather than drawing from established areas of psychology. The result is that we're gathering plenty of information, but perhaps short on understanding the information we obtain. My dissertation outlines a relational psychedelic science grounded in attachment theory, one of psychology's most enduring and influential frameworks. Originally focused on childhood development, attachment theory now informs nearly every domain relevant to psychedelics, such as lifespan development, self-regulation, relationships, mental health, psychotherapy, neuroscience, and even spirituality. As Professor Van Elk outlined, psychedelics effects unfold through many different interacting mechanisms. They produce acute effects on perception and cognition and potentially foster longer-term outcomes. Ostensible therapeutic effects of psychedelics are often attributed to the rich, varied experiences they can evoke. And these experiences tend to involve relational themes, such as unity, connectedness, and love, with a range of relational targets. Moreover, psychedelic experiences and their effects are influenced by contextual extrapharmacological factors, often called set and setting. However, more precise theories are needed to unpack the relational dynamics involved, both in the experiential element, as well. How did it sense that I was in the experiential element as well as the contextual element? It is this relevance of context, of relational factors and subjective experience that motivates the use of attachment theory in psychedelic research, as well as shared neurobiological processes such as the serotonergic action and neural circuitry common to both psychedelics and attachment learning, as well as experience contingent mental models that have been influential in the field. Developed by John Bowlby, attachment theory describes a psychobiological system that motivates humans to seek and maintain proximity to stronger, wiser, and caring others, called attachment figures, in times of distress. Attachment figures serve a dual function. As a safe haven, they provide comfort and protection in times of need, and as a secure base, they support exploration, skill development, and goal pursuit. These are the so-called normative processes of attachment, but also individual differences emerge from formative relational experiences. Such experiences are internalized as internal working models, mental models of self and others, which guide, they have sweeping ramifications for social and emotional functioning. On the one hand, responsive caregiving fosters felt security, positive mental models, and adaptive self-regulation. And by contrast, insensitive or abusive caregiving fosters attachment insecurity marked by negative models and maladaptive self-regulation that undermine these processes. By adulthood, internal working models consolidate into stable patterns of relational cognition, emotion, and behavior, also known as attachment orientations. There's decades of research that support these ideas that attachment security buffers anxiety, promotes growth, and enhances social emotional functioning, whether it is dispositional feelings of security or feelings of security made contextually salient by the environment. By contrast, feelings of insecurity undermine these processes. Attachment theory also has been fruitfully applied to religion and spirituality to describe principally the experience of a personal bond with supernatural figures or non-corporeal attachment figures and related beliefs and behaviors. However, it can also apply to feelings of transcendence and connectedness that don't have formal religious interpretations. In the following section, I outline 3 key proposals for synthesizing the literature on attachment and psychedelics to stimulate cross-pollination and guide future research. First, attachment security influences the way that people experience psychedelics and integrate these experiences. The uncertainty and emotional intensity of these experiences activates the attachment system, triggering internal working models and defenses. In a scoping review of predicting divergent experiences with psychedelics, Day et al. Emphasized that the quality of experiences relies on the ability to quote unquote surrender or let go, and to be able to more openly experience the drug effects. And this can be facilitated by attachment security or undermined by security. Thus, individual differences in attachment ought to be associated with divergent quality of experiences with psychedelics. And you can see in a diagram here that absorption, openness, acceptance, and surrender are all qualities that have a strong relationship with attachment as well, and so therefore these. And you can see that they are associated with a higher degree of mystical effects and a lower degree of adverse effects. And the converse is true for preoccupation, apprehension, and confusion, which are also heavily attachment based. There is some preliminary evidence for this proposal from a pilot study of psilocybin-assisted group therapy among men with long-term AIDS experiencing demoralization, Stauffer et al. They found that attachment anxiety was linked to mystical type experiences, and attachment avoidance was linked to a greater degree of challenging experiences. Again, the study had a number of limitations that Michiel discussed. There was a small sample size, no control group, but it's still an early indication, early signal that this is a worthwhile hypothesis to explore. Second, increased attachment security is a viable clinical outcome of psychedelic therapy. Psychedelics are purported to relax the strength of beliefs or priors, thus including attachment priors, which can be rigid and very stable throughout adulthood. And thus, under the influence of psychedelic-assisted therapy, a new space can be created for relational experiences to occur and new attachment patterns to develop. Though these mental models are deeply ingrained, psychedelics may temporarily reduce their influence. And then when meaningful subjective experiences are paired with a supportive therapeutic relationship, favorable revisions of attachment models may be possible. Third, attachment-related dynamics are mechanisms involved in potential benefits of psychedelic experiences, in other words, on other clinical outcomes. I mentioned that attachment theory revolves around reactions to distress and attempts at restoring feelings of security. When psychedelics induce favorable subjective effects in a safe and supportive context, the holistic experience may enable the relearning or updating of attachment-related models to extinguish learned expectations for abandonment or otherwise unsupportive responses that may have been experienced earlier in life, to revise presently maladaptive models in favor of security. And through these attachment-related experiences, other clinical improvements may be feasible. This excuse me. out of control here. This theoretical framework was the subject of my first dissertation paper. I then conducted 3 empirical studies to examine hypotheses related to these proposals. In study 1, we examined whether psychedelic phenomenology would be connected to people's attachment-related experiences in close relationships, both in recollections of their parents' caregiving and relationships in adulthood. Psychedelic experiences are described often as transformational moments, yet few studies have explored relevant developmental considerations. To evaluate the first agenda proposal, we examined whether psychedelic phenomenology was associated with perceived attachment history, as well as attachment orientations in adulthood. We hypothesized that differences in attachment models would predict different psychedelic experiences as outlined in the first agenda proposal. Second, we asked whether presumed links between a perceived insecure attachment history and later insecurities in adulthood could be attenuated by aspects of psychedelic phenomenology. This question is only an indirect examination of proposal 2 because we don't specifically test changes in one attachment variable, but rather whether the phenomenology of psychedelics can attenuate the link between early insensitivity and later outcomes and facilitate favorable changes in attachment development. For attachment in childhood, we asked a series of questions about whether each parent was sensitive or insensitive, aggregating the scores, with higher scores indicating more insensitive caregiving. And for attachment in adulthood, we used the widely used experiences in close relationship scale, which has subscales for both anxiety and avoidance. For subjective effects, we used also very popular, widely used scales in the psychedelic field: mystical type experiences, challenging experiences, ego dissolution, and emotional breakthrough. And as hypothesized, perceptions of an insecure attachment history with parents in childhood were associated with all facets of psychedelic phenomenology studied, with higher levels of insensitive caregiving being associated with greater degrees of these experiences. However, surprisingly, we found that associations between attachment orientations in adulthood and psychedelic phenomenology were nearly all not significant. And then to test the second question about phenomenology attenuating the link between the two, we ran hierarchical regressions to see whether the phenomenology moderated this link. And contrary to our hypothesis, in most cases, subjective effects did not moderate attachment development as operationalized here, where the only significant interaction was between mystical experiences and attachment anxiety. However, instead of weakening the link, mystical experiences strengthened it. While unexpected, in other words, to the degree that a person reported a greater degree of mystical experiences, the link between early insensitivity and later insecurity was stronger. While unexpected within a narrow scope of psychedelic science, it does align with concepts from the attachment and religion literature, namely the compensation pathway, which suggests that insecurity may predispose people to having spiritual experiences. Intense psychedelic experiences may reinforce insecurity rather than resolving it, especially without therapeutic support. And I want to stress that the study was conducted in naturalistic environments. Psychedelics are also frequently used with the intention to sort of, quote unquote, heal attachment wounds. This is one of the more popular threads in the pop science of psychedelics. This intention of I want to heal my attachment wounds may actually counterintuitively reflect insecurity rather than sort of a therapeutic intention. Right, within it, the attachment literature is sort of a preoccupation with attachment-related concerns, whereas feelings of security would enable more thorough exploration of the environment or of consciousness or the experience more broadly. It also raises questions about whether therapeutic change in attachment is best conceptualized as shifts in appraisals of early experiences, or it keeps happening. Whether clinical improvements in attachment would be better conceptualized as shifts in the same attachment variable, right? Before psychedelic experience to after psychedelic experience, I have different appraisals of my childhood or of my current attachment relationships in adulthood, or whether, as we studied it, the viable clinical outcome would be a reduced impact, a mitigated impact of early insensitivity on later outcomes. There are a number of limitations in study one. For example, to avoid biasing respondents towards psychedelic enthusiasm, we asked them about their most memorable experiences, whether positive or negative, but this may have also introduced other biases, like towards more intense experiences rather than, sort of a mundane, whatever you would call a run-of-the-mill psychedelic experience. In addition, this research was part of another study of psychedelics and spirituality among Jews. And so the sample was highly specific. It's possible that we wouldn't have found the same thing in other cultural contexts. And lastly, the sample had a high rate of mental health history, with 60% of the sample reporting at some point being diagnosed with a mental health disorder, which is quite striking, which, maybe also should motivate maybe the feeling of instability or mental health history may also be a predictor of later seeking of psychedelic use. I'll note additional limitations common to all three studies toward the end. That keeps happening. What is that? Okay. The second study investigated therapeutic mechanisms of change in the context of psychedelics. Study 2 conceptually addresses the third agenda proposal, that therapeutic benefits may be driven by attachment-related corrective experiences elicited by psychedelics, ostensibly. Psychedelics have been called catalysts of therapeutic processes, as well as psychotherapeutic drugs, quote unquote. However, there's been a disconnect between how psychedelic research has studied phenomenology, subjective effects, and how psychotherapy research is conducted. This has resulted in confusion about how to map psychedelic phenomenology onto known processes of change in psychotherapy that are both theoretically grounded and empirically based. Earlier, I presented this model of psychedelic effects, and when I say that, if psychedelics have therapeutic benefits, it's through processes known to us from effective psychotherapy. In the pink box. They encompass so-called common factors across therapeutic modalities. And a very influential account of these common factors is by Klaus Graue, his model of general change mechanisms, which are grounded in decades of empirical research and theory. These processes are highly relational and involve attachment-related states, feelings of safety and security, relevant to how people navigate psychedelic experiences. In fact, actually, attachment is one of the four core psychological needs that Graue puts at the center of his model. We investigated corrective experiences, relevant contextual factors, and parallel of these experiences in psychedelic phenomenology. In addition, we assessed whether these change mechanisms drive therapeutic effects. One second, excuse me. This study too involved an online cross-sectional survey, and participants were administered scales for well-being and stressful life events and asked to report on a specific psychedelic experience they'd had in the 5 years prior. And they were asked to report details of the experience, as well as being administered a series of psychometric measures, which included commonly studied aspects of psychedelic phenomenology, as well as the novel measure of change mechanisms. Full details of the development of the general change mechanisms questionnaire, it's a little beyond the scope of the presentation today. The details are in the published article, but briefly, the mechanisms are as follows. Resource activation, number one, which are experiences that engage approach-related motivation rather than avoidance. In psychedelic contexts, this sometimes comes up in peak experiences, so-called, or transcendent experiences. Number two, problem actuation. Clients must directly engage with their problems and their associated emotions. Under psychedelics, people may experience more directly and more openly psychological issues that perhaps during the day-to-day are suppressed. Number three and four are clarification and mastery, which refers to both gaining insight into problematic patterns as well as learning adaptive coping strategies to navigate them in a new way. And number five, the quality of therapeutic relationship, which in psychotherapy research is one of the most robust predictors of outcome. However, unlike other tools used in psychedelic research that typically focus on rapport in the preparatory sessions and integration session, the tool that we used is meant to tap feelings of being supported actually during the experience of the acute effects of psychedelics. Obviously, the relationship domain is most obviously relational and attachment relevant, but the others are as well. Remember from the introduction, I mentioned the links of attachment to motivation and self-regulation and intrapersonal phenomena as well. And so we conducted structural equation models regressing general change mechanisms on setting categories to assess whether certain settings were more conducive to these therapeutic processes. And we found that in the therapeutic context, there was a strong positive association between all of the general change mechanisms and settings designed for a therapeutic purpose. Therapeutic psychedelic settings are often prepared with great care and support in ways that boost individuals' feelings of security. We also found that in ceremonial, religious or spiritual settings as well, these settings were positively associated with all of the GCMs except for the relationship factor. While ceremonial contexts are not explicitly therapeutic, they are also designed with deep intentionality often, which can indirectly boost feelings of security as well. And the non-significant finding of the relationship, points to perhaps relational experiences or feelings of security coming from the phenomenology itself. An experience of, as Michiel mentioned, of a ostensible divine encounter, as it were, whether that's in the person's experience itself or whether this is scaffolded by the facilitator in the integration. Results for nature-based settings were a little mixed. I won't spend too much time on that today. But in contrast to the therapeutic and ceremonial settings, recreational settings were negatively associated with all of the general change mechanisms, except for the relational factor. This might indicate sort of a positive social experience without a therapeutic direction. Overall, these findings indicate that therapy-like experiences can also occur during psychedelic experiences, whether an explicitly therapeutic context or another psychosocial context that encourages introspective attention, acceptance of negative emotions, and interpersonal trust and support. These settings can boost feelings of safety and security and foster more therapeutic experiences. Then we examined whether general change mechanisms moderated the link between life adversity and well-being. Over here. As hypothesized, the association between stressful life events and well-being was significantly moderated by resource activation, clarification, and mastery, but not by problem actuation or by the therapeutic relationship. I'll get into that. These results emphasize that benefits of psychedelics, ostensible benefits of psychedelics, here counteracting the effect of adverse of life stress on well-being, may depend on known processes from psychotherapy. By contrast, it also shows that problem actuation alone, without a counterbalance of something more constructive, may not be therapeutic. This aligns actually generally with psychotherapy research. For example, when conducting overly intense exposure therapy without providing the client first with self-regulation tools or resources that they can draw on to successfully complete the exposure, that could result in a negative outcome from that session. Contrary to our hypothesis, the relationship factor actually did not significantly moderate the association between stress and well-being. Relational support may function differently than the other GCMs, whereas mastery and clarification may directly result in new patterns in how I cope with life stress. The relationship may lead to outcomes that are less linear in therapy, such as mentalizing or increased self-compassion, which take time to unfold and don't unfold in linear patterns, especially and maybe influenced by dispositional personality variables as well. Yeah. And also due to the relevance of corrective experiences, both to general change mechanisms as well as attachment theory, we wanted to see whether these mechanisms of general change, of change in therapy would classify neatly into different profiles. And so we set out to do a factor mixture modeling in this other diagram. To see whether there were different sort of profiles and subtypes of psychedelic experiences and whether they predicted divergent outcomes. And the model with the best statistical fit found 5 profiles: a moderately therapeutic experience, a highly therapeutic experience, a resource-focused experience with a high score on resources, but not as much the other scales, a problem-focused experience, which is overlapping but not the same as what's called in the field challenging experiences. Right, confronting a psychological problem is not by definition challenging. The challenging construct in psychedelics usually refers to feelings of anxiety and panic related to the drug effects, whereas problem actuation doesn't necessarily have to be distressing if it's allowing you a more clear experience with a presenting problem that would have brought you to therapy, as well as a non-therapeutic experience. And so in then comparing the different profiles to different outcomes, by a large margin, the greatest likelihood of having a so-called highly therapeutic experience, as defined by the factor mixture modeling, was among those who used the psychedelic in a therapeutic context. So highly therapeutic experiences are most likely to occur in psychosocial settings that promote feelings of safety and security, further supporting the contextual experiential framework and the relevance of relationality. I'll discuss limitations of this study after study 3 because studies 2 and 3 used very similar methods. But briefly, this study indicates that psychedelics can promote favorable outcomes via processes known to unfold in effective psychotherapy. And so therefore, psychedelic therapy may be best understood as the intentional creation of those conditions that enable known psychotherapeutic processes. Zach. Study 3 delved further into the relational context of psychedelic experiences. Here we hypothesized a dual role for therapeutic support. First, by buffering the potentially detrimental effects of life stress on challenging experiences, right? The more adversity in someone's life, the more likely they are to experience difficulties with a psychedelic. And therapeutic support can buffer that link. And second, the effect of challenging experiences on outcomes may also be buffered by therapeutic support in what's called in the field integration. In so doing, the study incorporates both immediate context factors, that of the immediate psychedelic setting, as well as broader subordinate context factors, the broader life adversity that a person may be experiencing when they come to a psychedelic experience, right? A psychedelic experience doesn't occur in a vacuum. This study is largely the same method as study 2. Here we also assessed both proximal and distal factors as well, vis-a-vis the reported psychedelic experiences. Sorry. Participants reported the valence of the psychedelic experience, to what degree the experience was positively valenced or negatively valenced. as well as the impact that they attributed to the experience on coping and well-being, as well as concurrent mental health at the time of participation in the study, which was at maximum 5 years later, which we did with the SCLK9, a measure of global psychological symptom severity. And then we also assessed therapeutic support in two different ways, both as a dichotomous variable, asking participants whether or not the setting was intentionally designed to be therapeutic, or as well as the subscale, the relationship subscale from the GCMQ, which assessed the degree to which they experienced feelings of being supported during the acute effects. We found for comparisons between on the dichotomous variable of therapeutic settings versus non-therapeutic settings, that these associations were generally mixed and may be affected by the disparity between the two groups' sizes, or the number of individuals reporting a therapeutic experience was dramatically smaller than the other group. And so those findings should be interpreted with caution. But in bivariate correlations, using the continuous measure of therapeutic support, unsurprisingly, we found this measure to be positively associated with more positively valenced experiences with psychedelics, as well as a greater self-reported impact of the experience on coping and well-being, and lastly, inversely associated with challenging experiences and distress. Then to test the interaction of life adversity and support, we used a hierarchical regression. And we found no evidence for the interaction of life adversity and therapeutic support on challenging experiences. In other words, the first half of that conceptual model. However, in the second half of the model, there were significant interaction effects in regressions of support and challenging experiences in the prediction of outcomes. I think most interestingly, for the impact of on coping and well-being, at low levels of support, challenging experiences were inversely associated with outcomes. In other words, what we generally find that the more distress a person experiences with the psychedelic, the less they are likely to experience outcomes from the experience. However, at high levels of support, the association was inverted, so that challenging experiences were actually positively associated with outcomes. And so, although challenging experiences may be unpleasant, they don't preclude experiences that are overall therapeutic. And therapeutic support may provide a balm for challenging experiences, which corroborates prior research on how support can soften the blow of quote unquote bad trips and even help make them therapeutic. I would venture to say that this is also the general approach of psychotherapy, that we don't when we want to explore the nature of distressing experiences and their putative root causes and their maintaining mechanisms, this often involves aversive emotions, right? You don't come to therapy to, have a good time, a pleasurable time, but ultimately through exploring those aversive emotions and maybe even having, the corollary of a challenging experience, that ultimately therapeutic outcomes may be obtained. And so overall, the data generally supported the theorized dual function of therapeutic support, even though the interaction effects weren't so consistent. These studies here, studies 2 and 3, all the studies, share some limitations as online cross-sectional retrospective survey studies, which involve recall biases, and limitations on causal inference. While each study took steps to mitigate these limitations, results of all of them should be interpreted with caution. The broad possibilities suggested here should be explored further in prospective longitudinal studies and experimental studies to directly investigate, for example, changes in attachment security, in-session behavior in clinical environments, or trait-state interactions for predicting different subjective effects with psychedelics and ensuing outcomes. Moreover, my discussion focused on therapeutic settings and clinical or therapeutic processes, but the studies presented were not in clean clinical conditions and using clinical samples. Nevertheless, clinical considerations were present throughout, including also a high prevalence of mental health history in therapeutic settings. And also more fundamentally, though naturalistic settings have limitations, therapeutic processes can also occur in settings outside traditional therapy where contextual conditions foster safety and support. And also psychedelic research sometimes involves a self-selecting enthusiastic sample, and so that should be borne in mind as well. As Michiel mentioned yesterday in the talk, we always want patients to sort of have hope and optimism about a treatment, and this is, predictive of future outcomes. But especially in this field where expectancies are so predictive of outcomes, it's important to take that in mind. Before closing, scholars have noted that psychedelic science involves a number of serious challenges that studies have not always navigated successfully, which raises doubts about emerging findings. Where relevant in my studies, I've tried to implement these suggestions to avoid repeating mistakes of earlier psychedelic research and managing the hype. For example, including disclosing all measures and analyses, publishing null results, and detailing all recruitment and inclusion-exclusion procedures, as well as avoiding making inferences that are unsupported by analyses. I echo the call to improve the quality of study design to address these threats to validity, generalizability, and replicability, which will help evaluate the relative strengths of already published studies, but also inform future work. And in the meantime, the field would be wise to balance the optimism about psychedelics with cognizance about the dangers of making unfounded claims about the state of the evidence. Just as one example, these Newsweek covers are separated by, I think, 35 years, but the same sort of messaging about this miracle cure, right? And so I think it's very important to contextualize whatever we're doing in psychedelic research and what we already know about psychological change. So in closing, this dissertation offered and began to test a paradigm for relationally oriented research into psychedelics based primarily on attachment theory. Hopefully, future research will continue to facilitate the transdisciplinary exchange needed for further maturation of this re-emerging field. Thank you very much.
Thank you, Aaron. And now we will hear the discussion between Aaron and the opponent.
Okay, then I think we are ready to continue. Thanks for the very nice overview of your work, Aaron. And I would like to start with making some positive remarks about your thesis, obviously, because I think it's really the first of its kind also in Sweden, I've heard, to do a PhD on psychedelic science. And it's also unique in that you apply this idea of general change mechanisms to psychedelic therapy and point out the need for assessing common factors that might be at play in psychedelic therapy. And as such, I would also like to commend you for crossing boundaries between different disciplines and bridging different literatures, predictive processing, attachment theory, general change mechanisms, using diverse samples and methods across the different studies, really exploring new territory. Using contextual experiential models, calling attention for the role of contextual factors at play, the role of set and setting and the broader matrix, and presenting a very nice and coherent set of studies focusing on, as you've presented, lifespan development variables and psychedelic experiences, general change mechanisms and how to measure them in psychedelic therapy, and therapeutic relational support in facilitating more positive experiences and mitigating the risks of challenging experiences. All studies have been published in nice publications, and I saw that next to that you have also a couple of other publications, which shows that you've been extremely productive in your PhD. And also the concluding remarks and therapeutic implications are really well discussed. So my positive comments for all your work, but of course I'm also here to make it a bit more difficult for you and to actually push back on some of the ideas that you propose. But before doing so, I would like to reflect you on the intro of your thesis. So I was actually happily surprised by the personal intro that represents your unusual journey in this field. And there you also take a step back and reflect on your personal background in relation to the topic that you study. But I would like to reflect you in a bit more detail on what are the added benefits, according to you, from your Jewish perspective on religion and the use of psychedelics within that context. Because, for instance, at several points in the thesis, you reflect on the distinct cultural frameworks that Jews might bring to psychedelics use, without really further explicating on what those entail. And in study one, you used a sample of Jewish participants, and you make the remark that this is a kind of unique sample, but what makes it unique and what kind of resources might people bring with this background compared to people with a different religious background? Maybe you can reflect on this a bit more.
I think, just as an example, one of the more recently advanced frameworks for psychology of religion and spirituality, sort of the four domains, of beliefs, believing, bonding, belonging, and behaving, I think, but advancing sort of behavioral, sort of ritual aspects of religion, as well as sort of affect experience, as well as communal experiences, and sort of the direct, the ostensibly direct, feelings of transcendence that spiritual engagement provides, which differ in different. I think, in particular, Jewish context, the sense of community is really salient. I think that, as you said in yesterday's talk, to sort of ground these spiritual experiences in frameworks in everyday life. And so, specifically Jewish samples, there are a lot of behavioral components where we're on a daily basis, we're making salient these religious beliefs or past experiences, or even sort of, national experiences, part of our daily lives that exists, I think, to varying degrees in every religious context, but those are sort of the directions that I'm looking forward to further exploring in the data for future work.
Okay. And how might those come and play in psychedelic experiences? And do you actually have evidence that indeed it affects what people experience, or that they have different resources or rituals for dealing what comes up in a psychedelic session?
Evidence, not. I haven't conducted those analyses yet, but I think what's typically assumed or spoken about is that, even my clinical psychedelic training, the supervisor said, we need to take advantage of the neuroplasticity, right? So in order to, if there's nothing done with neuroplasticity, then for what are we becoming more malleable if we're not learning something new, right? So patients from every background are encouraged to make some behavioral change. So whether that means choosing ahead of time some new practice to take on, or to do it a different way, to give more symbolism, to use the symbolism from the experience in a psychedelic experience to further inform that ritual beyond. I think
Yeah, I'd be curious to learn more about that in your future work.
Yeah.
But maybe I would like to start with a few more broad perspective questions about the topic that you investigated. And the first concerns the role of therapy in psychedelics. As you might know, given the rejection of the FDA of MDMA-assisted therapy, we see an increased movement towards moving away from therapy and actually focusing more on drug action. So people have started to realize that it is really difficult to get approval for therapy from regulatory agencies. So hence they try to market it more as a drug. So MDMA can have the effects it does on PTSD due to its empathogenic effects, or psilocybin can be administered safely with minimal therapeutic support. And Guy Goodwin, the CEO of Compass Pathways, has the famous remark, even a cleaning lady could supervise a session. How do you see this trend? And how do you consider the role of therapy in psychedelic therapy?
So first I'd say I'm not, I don't think the only place where psychedelics can or should be used or should be limited to as sorry. Sorry, could you repeat the last line of the question?
Yeah, so according to you, what is the importance? So you did a lot of research on contextual factors in
Right.
therapy, at play, the dynamics. So you seem to think that therapy is important, but what makes you think that therapy is important compared to this more biomedical approach, where it's just a substance inducing a mystical type experience?
Yeah, so I don't mean to say that psychedelics, should only be used in a clean clinical environment. The point is to suggest that when psychedelic experiences are therapeutic, it's because they are activating these known processes of psychological change. That's so, could that happen with a trained therapist? Could that happen, at a rave? Could that happen with a friend? Sure. I think that the highest likelihood of having that experience is in, a properly prepared psychotherapy, not just the therapeutic environment, but in the context of more robust psychotherapy where intentions are being explored, desired therapeutic outcomes are really, explored through motivational interviewing, for example, for a number of sessions, and patients are given tools so that their experience with the psychedelic can be agentic and that they can really use it, because like you said yesterday, the evidence about psychedelics therapeutic effects as sort of a drug response phenomenon is sort of mixed, and so we can make more probable these therapeutic benefits by enveloping a psychedelic experience in a psychotherapeutic process that's already taking place. I think one of the reasons why personally I'm glad that MAPS didn't get the approval for MDMA, even though this set us back chronologically, is that their psychotherapy model wasn't really well defined. It was sort of informed by alternative frameworks and not in empirical studies of how people change their health behaviors, for example, or their thought patterns in therapy. It's inconvenient, but I think it's ultimately better for us as a field that we sort of detox or monitor ourselves and not just rely on an external policeman to
Guard us, yeah.
Yeah.
But I am very much on the same page as you, I think. But at the same time, doesn't the data of your thesis partly speak against the importance of therapy? Because, for instance, if we would go to page 61, where you just presented the table also on the slides, where you make a distinction between different therapeutic intentions or different contexts in which psychedelics are used. What really stood out to me is that, of course, for the GCM questionnaire measuring common factors, you find the highest scores for the therapeutic group, but you find similarly high scores for the ceremonial group.
Right.
So even in a context without any therapeutic support, but just a shaman being present, you find already that similar factors are at play and could actually drive therapeutic benefits. And also in study 3, you find that both therapeutic and non-therapeutic context groups show quite similar relationships between stress, challenging experiences, and outcomes. So that raises the question, to what extent is actually a therapeutic setting important to reap the benefits of a psychedelic experience?
Sure. So, first there are some limitations on how we were relying on the participants to self-label that the setting was intentionally therapeutic. So there's a limitation there. To speak to study 2, I think there's a difference between assessing the therapeutic relationship while experiencing the acute effects of psychedelics versus the pre-session rapport. And maybe it's possible that while the pre-session rapport and post-session rapport, therapeutic alliance is more important than feeling the support coming from the facilitator. The individual questions, I think the questions are in study 2 in the back. Page, if you go to the second published article, the third published article, page 445, with all the individual questions of that measure. So the items for the relationship subscale are explicitly framed as, I felt that the facilitator, I felt safe with the person I was with, right? The clinical and the non-clinical. So I could trust the person I was with. And so Maybe a limitation of this measure is that it's asking the participant to specifically praise the relationship as doing the thing rather than as doing the thing, as having benefit, rather than attributing it to the mystical, the whatever subjective effects of the drug. And so even though the participant doesn't label, all right, if we think about it ontologically, rather than how it's being appraised by the participant, it's possible that the therapeutic relationship is having effect through the other GCMs. I actually haven't told you yet, but I got a grant to further explore this data in a more hierarchical model to see if the relationship factor is driving the other factors.
Okay,
Which are nested. And so even if the patient doesn't, or the patient, even if the participant doesn't attribute it to the relationship, that doesn't mean that the relationship isn't providing something more amorphous that makes the other GCMs more likely to happen.
Yeah. And how would you then characterize what wasn't clear to me, the recreational group?
Yeah.
How did that differ from a ceremonial group or a therapeutic group?
Oh, sorry, I didn't get that. So even though ceremonial is it's different than a therapeutic setting in some of the surface level details, but in ceremonial settings, this speaks to sort of the religiosity question, but one of the, at least in a Jewish perspective, one of the main aspects of doing rituals or having communal practices or experiences is first setting what's called an kavanah, an intention, which is also a widely used term in the psychedelic field. And so whether that intention is explicitly therapeutic, I want to explore this pattern of mine and experience symptom reduction, right, and in a very sort of clean way, or whether the intention is we're going to have a unifying experience. So that can also have the boundaries there are kind of murky between ceremonial and therapeutic, because there's also intention being set, even though there might not be the intention and the goal may not map onto sort of symptom reduction, but it is something of therapeutic value, as you discussed yesterday, I think, in the network model where you presented that the spiritual intent was the strongest predictor, right, of benefits.
But what makes the recreational setting different? So there's a group that actually scores negative on some of those factors. So
yes,
what defines a person doing psychedelics for recreational purposes?
So
just for fun, or
we gave a couple examples in the study, examples to the participants. We listed as an example rave, nature party, at home, not with the. It's possible also in a sort of sometimes a recreational environment can also have an intention to have fun, right? That's also an intention. But actually, I didn't present on it today because this will be on the scope, but we have in the GCMQ paper also tying the divergent experiences to different intentions. And so we have also a therapeutic intention and a escapist intention, a hedonistic intention. And so, I think we should explore in further longitudinal research how the intention and the setting interact. Right? We talk about set and setting. And so maybe we should explore how the setting and intention interact. But generally the recreational group, saying that I wasn't in a shamanic or ceremonial setting. It was just for fun or to explore or.
Okay, that is clear. So that can not be beneficial for triggering those common factors.
Yeah.
I would like to move on to figure 3.1 on page 65, where you use latent class analysis to identify different profiles of people based on the GCM scores.
Sure.
And I think most of the groups to me made sense theoretically and intuitively, but one that stood out to me and that I would like to reflect you on in more detail is the problem-focused experience group. So this is a group that scores quite low on all common factors except problem activation.
Sure.
And what is going on in this group? What makes them stand out compared to the therapeutic group? Like what makes a problem activation session different from a more general therapeutic session?
So of course, problem-focused experiences are an important part of psychotherapy, right? Even the problem activating experience is potentially therapeutic, right? In Grau's model, a so-called corrective experience is the interaction between problem activating experience, clarification, right, about the problem, and mastery of new coping skills, right? In his model, a problem needs to be directly experienced. Unless you are experiencing the tension of the problem, you're unlikely to address the problem. You need to really feel the tension that is causing you in your life.
Mhm.
So this is also an important part of therapy. But for example, when psychodynamic therapy or when sort of classic psychoanalysis is badly practiced, right? The person spends years in analysis getting a lot of clarity or feeling, really exploring the problem, but not sort of getting mastery about that problem, then it could exacerbate it, right? So if someone is only experiencing directly the tension that the problem is adding to their life, and not something paired with it that's more constructive, then it's unlikely to lead to a constructive place. But it's still an important ingredient of therapy to have that direct experience.
But could it be that this group is not interested in therapy at all, but is simply trying to solve a different problem, maybe something they're struggling within their work, or a breakthrough they're looking for, so that the high scores on the problem actuation is more related that they had an intention related to, I want to get insight in one specific problem. I don't need therapy, but it's actually hoping that psychedelic will increase my creativity or something like that. So you seem to be inclined to interpret it in a therapeutic.
Well, that problem, you're saying they might be experiencing a sort of personal problem that they don't identify as therapeutic.
Exactly.
So right,
work-related issues.
Right. So I think I would say that Grau's model is not exclusively for psychotherapy. Right here, I guess maybe I gave too disproportionate attention to therapeutic implication. But whether it's an attachment literature is also a corrective experience can occur outside of therapy with a romantic partner, with with a religious experience, and the general change mechanisms as well are not limited to psychotherapy. Here we applied them that way, but it doesn't require. In other words, even though we are defining the mechanism as potentially therapeutic, that doesn't mean it requires the participant to label it as such for it to be included that way. Actually, with the last article, we encountered some of the reviewer feedback that we got on the last article was, can you call these therapy? This isn't a typical therapy environment, and it's not the normal setting of therapy. That doesn't mean it can't be, have an impact that is therapeutic, right? Just to be wildly right. If I go to a yoga class, that could be a therapeutic, right? So even if I'm not conceptualizing myself as the participant, that I'm doing therapy, right? It can have a therapeutic effect, and I think that's where the labeling of it comes from. Even
that clarifies it a bit more. I was impressed also by the skill development article that is included in the supplement, the article of which the first author is Wolf.
Yeah.
And you refer repeatedly in the thesis itself to results reported in the supplementary article. Specifically, would like now to zoom in on, that is table 9 on page 4048 in the supplement. Because it ties in with the specificity of the general change mechanisms that you identify in the research. Because what I found interesting, if you look at the correlations between the instrument that was developed, and it seems to be central to the research in a study 2 reported, is, for instance, that some of the subskills of the newly developed skill correlate quite well with, for instance, the ego or the emotional breakthrough inventory. So the correlation between number 10 and number 2, 3, 4, the challenging experience questionnaire, the CEQ. You also see a high correlation with the 11 ASC, oceanic boundlessness, with factor 1.
Right.
So, I initially thought, this is actually nice to have a new instrument that can assess common factors in psychedelic therapy, given these high correlations, I became a bit more skeptical. So the positive interpretation is, well, the discriminant and convergent validity is good,
Right.
but the critical interpretation could be, what is the added value of this instrument beyond the skills that we already use in a lot of the trials in psychedelic therapy?
Yeah, it's a great question. So actually, David Yaden and colleagues published like last week or recently, subjective effects beyond a mystical experience, right? I think, sorry, I'll back up a second. I think just because they're, first of all, you're right that it's inconvenient. I think that it's unsurprising that they are correlated because mystical experiences, for example, can be very resource activating, right? If I am on a psilocybin trip and hear God speaking to me, and saying that I matter in this world, right? So that is both a highly mystical type experience, but it's also resource activating because now I have had this experience where I feel like I matter, and maybe I think about some reasons why I matter, and I think then I can have a therapeutic benefit. I think that as well, challenging experience. It's when having a problem activating type experience. I might also experience a lot of anxiety, but some people also describe, this is also predating my work in Klaus Grau's work, but that sometimes it can be even, while at times it can be sort of a relief to have a problem activating experience, right? I finally have clarity and I directly experience, wow, when I mismanage my time, it really makes me feel, whatever. So that can be a relief to finally have that clarity, but that can also be associated with a lot of anxiety. So on the one hand, it's not surprising that they're associated. On the other hand, that doesn't mean that they're exactly the same thing. And I think that's part of the motivation for conducting the study in the first place is how do we give language to, right? A mystical experience can be positive or negative, right? Just because a person has a mystical type experience doesn't mean that it's a good thing, which is sort of counter to the earlier Johns Hopkins work, where it's just assumed that mystical experience is by definition positively valenced and therapeutic. So part of the motivation for this study in the first place is how do we give terms to these subjective effects from psychedelic experiences that are more operationalizable, or that are more in line with what we do in psychotherapy. But just because they're associated doesn't mean they're exactly the same, I think.
Yeah, and this maybe also relates back to the point about the importance of therapy, because the critic of therapy would say, well, we see all the time high correlations between MEQ scores and therapeutic outcomes, and that's basically saying that just the psilocybin or the substance itself is driving a lot of these effects.
Yeah.
And how can you then disentangle that from whether the therapy is actually important? So what is actually first? Is it really the experience and then the therapeutic mechanisms, or is it all entangled? So if you would try to put it in a model and try to include the MEQ and the CEQ and the EBE, EBI as well, what would the model look like? Where would the arrows go in terms of?
It's a good question. If anyone here knows anyone who can provide the funding for such a study, they can contact me. But obviously, we would want to use a longitudinal, design or experimental design, whether clinical or sample or not. I would imagine sort of a partial mediation model where some of the, as we argue in the article, that if psychedelics provide a therapeutic benefit, it's because the phenomenology parallels experiences that are happening in typical psychotherapy, but also that the psychotherapy itself is providing something as well. I'm now perhaps more skeptical that mystical experiences alone would provide, before I got into this work, I was working in a religious community mental health hospital, and there, typically the sort of religious experience was not therapeutic, right? Especially when there's motivated reasoning behind how I interpret that religious experience. I think part of the role of therapy is really, as you said, a sober look at psychedelics, really giving a sober examination of that experience to make sure that the sort of spiritual element that I'm experiencing is not sort of a way of avoiding, more therapeutically central processes as well. So I think partial mediation model, perhaps with assessing suggestibility, which is also something that in hindsight we should have done in the study as well, to check that suggestibility is not just inflating both of those variables.
Yeah. And also to follow up on the GCM model and what you try to capture there, to what extent do you think the model is sufficient and complete? Because, for instance, on page 83, you also discuss attachment figures that might come up in psychedelic experiences, God and supernatural beings. And supernatural entity encounters might be another therapeutic mechanism through which attachment might be fostered or enhanced in a psychedelic setting. Which is assumed that under the different subscales of the GCM. But also, I was thinking other common factors, such as, for instance, shared worldviews between the therapist and the client, which I think is really key. So if you go to a therapist, you probably try to search for a like-minded person who shares the same values and beliefs to foster therapeutic alliance. Is this something that should be included as well? So
in the GCMQ?
In addressing common factors. So supernatural encounters as triggering attachment and shared worldviews and beliefs between client and therapist. Or is this subsumed under any of the current factors?
It's a good question. I think it'd be interesting to administer both, the working alliance inventory from psychotherapy research, as well as the GCMQ, right? The GCMQ is only assessing the degree to which I experience the therapist as supportive during the acute effects, right? So, I mean, it's a fascinating hypothesis. What is carrying most of the weight? Is it the pre-session rapport that me and the therapist agree on the goals of the therapy, the tasks of the therapy, and I feel a strong emotional bond with the therapist? Or is it, I think that's one of the explanations we give for the relationship scale not moderating, right? Not being a significant moderator of outcomes, is that maybe the relationship itself is less pivotal in the psychedelic experience because I'm experiencing so many other things. But you're absolutely right that the working alliance, the therapeutic alliance, is an important factor as well, and the comparable effects, the distinct effects should be compared.
And does it capture? So you have this RE subscale. Does that capture indeed shared beliefs?
I don't think so.
It's more about the relational.
No. It's the item. If we go back to the items, I felt safe with them. I could trust them. I felt comfortable with them.
Okay.
But I would also point out that the psychotherapy research itself is mixed on how much I need to agree with my. There was a recent study by a former mentor of mine about whether religious Jews need a religious Jewish therapist, right? So the question of do I need a therapist who shares my worldviews? It's also, I think, an open question because surely a person can experience, compassion or support from someone who they don't necessarily agree with. On certain, maybe
so corrective experiences might be triggered actually by the therapist who does not necessarily align with your worldviews yet.
Yeah, I think so. Maybe today everybody talks about how polarized our politics are becoming, and so maybe that's less likely nowadays. But I would like to think that people could still experience these positive relational dynamics, even if they maybe compartmentalize some worldviews.
Yeah, indeed.
Maybe also the reason I'm coming to therapy in the first place is because there are worldviews that I have developed that I want to separate myself from, right? And so I go to someone that that has more optimism than me about my future, about the world, about the cognitive triad of depression, for example. I think there's a lot of room in psychedelic science for the so-called dual process cognitive models. One of the papers I did before my PhD is implicit versus explicit experiences of God, for example, right? So do I does my declared belief about God being compassionate, loving, or punitive and vengeful, does that matter more than assuming a reaction time task really does reflect my non-conscious attitudes, right? So how do those things interact? And maybe do psychedelics alter, only declared metaphysical beliefs, or also, sort of non-consciously held attitudes about the world.
Important distinction indeed.
Yeah.
Okay, I would like to let me see how we're doing in terms of time. Well underway. Taking a step back, the broader perspective and the starting point of the thesis is also the relation between attachment and psychedelic experiences, and attachment both as a predictor and as an outcome, right? So it's a dynamic thing. So attachment security probably predicts how people respond, but the experience itself can also have an effect on attachment.
Sure.
And that is the background also of study one in the thesis, where you look at attachment history and you use the insecure attachment history measure, and also the experiences in close relationship scale as measures. And then you assess the relationship with psychedelic experiences. But when I first came across figure 2.1 on page 53, I was a bit puzzled by the analysis that you presented there. Because there you present relationship of mystical experiences as a moderator on attachment anxiety and insensitive caregiving. And my initial thinking was, what you're doing here is you're using a state measure as a moderator for two trait variables.
The state.
So the mystical experience is a state, and I tend to see attachment as a trait that is more or less stable.
Yeah.
And we typically tend to think of moderators as like stable differences that might affect how people respond differently to an intervention.
Sure.
So can you clarify the rationale of this analysis here?
Yeah, that's a good question. I think for the, first of all, we're asking people to, obviously we can't truly capture development in a cross-sectional study, right? But we are asking people to reflect on this psychedelic experience that they had that presumably occurred, chronologically between the insensitive caregiving and the current attachment orientations, fully coalesced, as it were. And so in that sense, I think it can be positioned as a moderator. I think the better, I'll do one better, is that I think that a good follow-up study would be comparing the, one of the things I mentioned in the presentation is trait-state interactions. Given the funding and the setting, I'd love to conduct a study that assesses both trait and state attachment over the course of a psychedelic therapy battery, right? So a person is reporting on the ECR, the disposition, the trait beforehand, as well as the state, before and after each individual session, and then maybe also the ECR throughout to see that it's really to see whether the pattern of changes in attachment is linear or whether there are what's called sudden gains in psychotherapy research. But absolutely, the question is a good one about trait state.
In favor of the analysis, I can also tend to see that you tend to think of these attachment and insensitive caregiving as a process or a developmental thing that can fluctuate over time, and that mystical experiences can affect how that relationship unfolds. So
Right.
the development of attachment.
Right.
But then you have this somewhat surprising finding that indeed, whether direction was it, that higher mystical experiences tend to actually increase the relationship, right?
Right.
And there I was thinking, so that is somewhat difficult to interpret finding.
Yeah.
Could that finding be explained by a third variable being into play in terms of like certain personality characteristics, maybe high absorption people
Sure.
being more prone to having stronger mystical experiences, but also scoring higher on attachment insecurity?
Right. So there's a number of things that could be, first of all, shared method variance, right? Or could be other traits like suggestibility or absorption. But in the attachment literature, there's a discussion of differential susceptibility, right? So it could be It could be that someone high in a trait of absorption or suggestibility, right, just generally over-reports. Although the way we assess caregiving, we had questions that were both directly coded and reverse coded, right? So then a person would be reporting, over-reporting insensitive caregiving as well as sensitive caregiving. But I think your question is a very insightful one because in the attachment literature, there's a framework for people being differentially sensitive to the environment that they're in or the experiences that they have. And I think this would be also a valuable direction to pursue in further research. Are there people that dispositionally are more, are more affected by a mystical experience than others? There's the same way that in attachment, development, even in the same home, even if the parents try to raise children in the exact same way, children may be differentially susceptible to those environmental effects, right? So I think that's something we should explore and further.
And that also points to the deeper question that the starting point of the thesis is a dynamic framework where attachment interrelates with psychedelic experiences, both as a predictor and an outcome. And this process unfolds over time. And the methods you used are cross-sectional and are basically capturing only one moment in time. So isn't there a discrepancy between the methods that you used and the theoretical aims that you try to achieve in trying to understand those dynamics? And if you were to do it again, how would you go about researching these dynamics?
Sure. So first of all, I'll say that there were plans for longitudinal design that because of my discontinued PhD funding and some, and COVID, those plans had to be scuttled. I did take great care throughout the CAPA to not appear to be claiming that I did assess development, which empirically, right, which requires change over time, but rather conceptually, factors that are developmental. Were I to do this again, if someone knows sources of funding, I would like to, assess different, attachment as conceptualized in the developmental literature, for example, the attachment interview, to really get into how attentional attention is how the mindset around attachment, maybe as well as some sort of inventory of adverse childhood experiences or insensitive caregiving. I'd like to, as well as triangulate data, perhaps with a romantic partner also providing some, before and after. As I mentioned, I think already when we were discussing the trait and state interactions, assessing, attachment pre and post and follow up, but also sort of interspersed throughout, right? The question was if I would do this.
As well. What type of methods might be suited? So did you also think, for instance, about doing interviews with therapists? To get insight into to what extent attachment dynamics come up in psychedelic sessions.
So and in-session behaviors. My master's thesis was on, coding in-session behavior in psychotherapy, which I think, would encounter some novel challenges in the psychedelic setting, but, to find some way to assess that as well. The APEC that we reported on in study 2, paper 3, is about that. There's a subscale for, to what extent the experience was an interactive one versus an immersed one, right? So I think that's, relevant to attachments. Usually in attachment, the degree to which a person can explore is adaptive, right? Interact is adaptive, but maybe in the psychedelic environment where a person is specifically instructed to go inward, right? To put a blindfold and to explore inward, then talking to the therapist or the people in the setting is counterproductive, right? So that's something I think would be valuable to triangulate with the pre and post measures as well. As well as different relational targets, whether within the attachment literature, there's a discussion of earned security, right? So maybe through an experience of feelings of security during the experience, I can experience feelings of safety and support that weren't accessible to me through earlier relationships. Yeah, absolutely. All those questions would be valuable, longitudinal, experimental.
Limited time and funding.
Yes.
There's a lot to explore. This also piques my interest in the next question I had written down, and that is your thesis does not really distinguish between different psychedelic substances. So I made the distinction between the dissociatives, the empathogens, the classical psychedelics. And I can imagine that, for instance, ketamine-assisted therapy compared to MDMA-assisted therapy might pose different challenges with respect to attachment, therapeutic alliance, change mechanisms. So what would you predict about these mechanisms in terms of differences between substances? And to what extent do your findings say something about this, have information about this, or do they generalize across these different substances?
Studies 2 and 3 are only about classic psychedelics, and specifically longer acting ones. So we didn't include 5-MeO DMT. And so I think there is a bit of an error scope. More broadly, I would say that as you were speaking about yesterday, that there are many pathways to these different kinds of experiences, and maybe the field will find that there are very substance specific effects both in phenomenology. But I think that to really understand whether and how psychedelics are leading to therapeutic benefits, we need to pair that understanding with really investigating how experiences of all types are reflected upon and integrated. And so to that extent, the therapeutic process around the experience may prove in the future to be more determinative than the specific substance anyway.
But wouldn't you a priori predict, for instance, that MDMA might be much more conducive to fostering bonding and therapeutic alliance and hence attachment than, for instance, psilocybin, which is much more unpredictable in terms of its subjective effects?
I think, first of all, you're right. However, I think this is a problem that we've run into in the clinic where I work with ketamine-assisted psychotherapy, where I have patients saying, I don't yet feel safe or ready for this work. Which my response to them is, if you're not feeling ready to do this work and you don't feel like you can trust me enough to be vulnerable, then I don't want to induce your feeling, open and vulnerable with the drug, right? So I think this is a tricky question because on the one hand, yes, the drugs can have a very powerful effect on social connectedness. On the other hand, in therapeutic environments, maybe we really want to seek out the strong therapeutic alliance through the normative relational processes and not by inducing it with a pharmacological intervention, where then maybe you're setting yourself up for failure in psychotherapy by making the patient feel duped or tricked, or when they feel like William James has a great quote about psychedelic experiences where the I'm butchering it, but where the revelations that I would have sworn by at the height of the acute effects are, under later sober scrutiny, nonsense. And, so I think that's actually, so on the one hand, you're right that it may be more conducive to inducing that, and I worry about establishing those processes on the artificial induction of connectedness and closeness.
Yeah, I can see that point. To what extent do you think it's important that the therapy with a drug is conducted by the same therapist as the preparatory and integration sessions, or can that be a different person?
Yeah, it's an excellent question. Yeah, it's an excellent question. I think one of the explanations we also gave for the relationship scale, if the relationship that's being formed around the psychedelic experience is very short term. It takes a certain amount of time for an attachment, bond to develop. So if that relationship is only taking place on a 3-day retreat, and even more so, 1-day festival. So attachment dynamics may be relevant insofar as they also relate to intrapersonal phenomena, right? Intentions and regulation, but not in the, immediately assumed sense of the attachment between the therapist and the participant. There, we would just want to ensure that the therapist has, basic competencies and, ethical practice of psychotherapy. I think that's a really important hypothesis for our field to explore.
Yeah.
Both because cost effectiveness of these therapies. Yeah.
And this also speaks to the issue that you shortly touched upon, the risk of false insights or beliefs that might come up in a psychedelic therapy session. Because one premise is that psychedelics can induce corrective experiences that can be beneficial,
Right.
but they can also trigger, as we have now encountered in the literature as well, false memories, for instance, of sexual abuse or maltreatment, etc., that turn out to be not grounded in actual or factual memories. So, for instance, there's a lot of research on recovered memories, and you partly addressed this in the general discussion towards the end. But can you maybe elaborate a bit more on this risk and how it can be mitigated, and how the relationship with the therapist is potentially important in that respect?
Sure. So I'll start by I think the discussion about false insights is slightly different than the discussion should we have about recovered false memories. And about memories, I'll say that I think the preparation work is very important. Participants should be instructed, patients should be instructed that a particular insight that they may have, at any particular point could be. They should be warned in advance that could happen. So that when it comes up, they're sort of less convinced or less certain that this is objective truth. I think therapists are well trained to, on one level, always be for the patient and accept the experience that they're coming and sharing, but because they're the focus of the treatment, we're also having sort of an analytic third, right? So that would be for memories. I think one of the more well-founded frameworks for understanding psychedelic therapy, for example, is acceptance commitment therapy, where all thoughts are viewed, right? Even in waking consciousness, all thoughts are viewed with a sort of skepticism, right? That just because I tend to have a certain thought more often doesn't make it necessarily true, right? The sort of cognitive action fusion, right? So in that perspective, any internal stimuli I am experiencing as something that, right, with the self as context model that I'm experiencing, but is not necessarily true about me or about my life. So that would be for insights.
But how do you educate false from true insights?
Yeah.
At the end of a psychedelic session and in the integration phase, what is the role of the therapist there to?
Yeah.
If there's any role at all.
Yeah, I think. Well, first of all, I think that's why So I think the preparation work is super important to set patients up for understanding that what they experience under the psychedelic is not necessarily true, even if it's meaningful and valuable. I think also the therapist should be upfront about their role, as we're not police investigators looking for objective truth about what happened, but seeking to explore the meaning of different experiences that have happened or may have happened or even are illusory experiences, right? The fact that I have this, insight, quote unquote, What is the meaning of having that recurring thought, and how do I incorporate that into my life and understand it? And we're not the whole goal, the objective of therapy is not to discover, I think you do have people who their intention for, taking a psychedelic is to quote unquote uncover these memories, which I think is a counterproductive, intention, because it's not really feasible and it sets people up for confused. There was even a prominent case in the news about this recently with a prominent donor of MAPS, that they wrote a selling memoir about a certain, recovered memory of sexual trauma. So, clients can be encouraged to sort of reflect on what that, if they have such a experience, they can reflect on feelings of vulnerability generally, right? Or the feelings of safety or vulnerability, and what can we do about that, right? What boundaries can we set up in life to, how can we increase our awareness for when our boundaries are violated, or, without leading the client on to believe that this is real.
Mm-hmm. Yeah, it's a tricky issue. I think, for instance, there's also a recent argument being made that even false insights can be therapeutically relevant. So even if people have false beliefs, they can help people by outsourcing problems to spiritual entities, etc.
Yeah, I think this is more aligned with sort of second wave CBT, right? In second wave CBT, where it's like, I have depression that's based on, these sorts of thoughts. And so if I change the thoughts, if I argue the thoughts, even if I don't really believe it at first, right, eventually that'll have some impact.
Mm-hmm.
And I think over time that approach has, it's been identified that approach has some shortcomings, right? Especially just as an example, the more I, argue with those intrusive thoughts, the more I train those pathways, and I reinforce that when I try to do battle with intrusive negative thoughts, the more I trigger new negative thoughts. And so that sort of gave way to third wave, behavioral therapies, where I'm not necessarily grappling, with the thought and coming up with beliefs that I'm not convinced by, to keep them at bay, but rather to change my relationship to thoughts without buying into any specific one.
Yeah, interesting. Yeah, thanks. We didn't touch it in detail on the third study that focuses on, so it is a nice theoretical model represented on page 70 that makes intuitive sense to look at the moderating role of therapeutic support on the relation between stressful events, challenging experiences, and outcomes. Then on page 72, you report the correlations between the variables that you measured. And there, what stood out to me is that the GCMQ relationship subscale is quite strongly correlated with both the valence, the coping, and the well-being measures.
Yeah.
So, although intuitively it makes sense to look at the moderating effect, isn't this correlation table more suggesting that it could be a predictor? So that relationship quality is basically predicting how positive people feel during the experience, and also how well they can cope, and also directly predicting well-being outcomes. So more in line with what we already know, that therapeutic alliance seems to be a key predictor of therapeutic efficacy in psychotherapy.
Sure. I wanted to, and so that's why the report on the bivariate correlations, I wanted to come up with a more, I wanted to explore whether, in other words, not only whether the relationship would predict those better experiences, but whether they would, like, what is the impact, like how is the relationship doing that? Which is obviously limited in a cross-sectional study, but conceptually, which is why we didn't just put all those things into one, moderate or mediation model, right? You're absolutely right that in future studies with greater statistical power and longitudinal designs, it would be worthwhile to explore whether the relationship is just directly predicting better outcomes, or whether the relationship has a specified, impact, right? What is the relationship doing in the psychedelic experience? Is it, whether it's, mitigating the impact of life stress on only the psychedelic experience, but then after that, it's not really the relationship, it's just the experience that carries over, or, the opposite. I think, and this is why I think the GCM is a really valuable tool, because it's not just taking at face value, what is the person experiencing under the acute drug effects, but what is the function of that experience?
Yeah, the process.
Yeah.
Provides better insight.
Which is also a development in recent psychotherapy, is understanding, that the same emotion or the same thought or behavior may have a different therapeutic import depending on what function it's serving in the specific context. We can process-based therapy or contextual science.
Out of interest, did you run the additional analysis looking at the direct relationship between therapeutic alliance and well-being, coping, etc., in a regression or mediation model?
You mean like everything at once?
Yeah, no. So you now report mostly on the moderation effect, but
Yeah.
you also simply look at the mediation or the predictive effects of the quality of the relationship.
I don't think we looked at that, but that's something
Okay.
that especially because some journals don't accept, won't even look at cross-sectional mediation.
Yeah.
I'm happy to explore that further in the data, but I when thinking about what type of publication would be a more valuable contribution to the literature, this is where we landed. But I'm open to therapeutic alliance being a mediator rather than a moderator. I think that's, as I mentioned, the grant that I got like a couple of days ago, is something that we can make part of that article.
Yeah, it would be interesting. Given the strength of the correlations, I actually would not be surprised if it would turn out to be a predictor. Let me see what also I have left. Now are we doing in time? Maybe also a question about the chapter in which you integrate predictive processing with attachment theory.
Yeah.
So I think it's a nice crossing of two literatures and integrating ideas from predictive processing account of psychedelics with attachment models. One thought that came up is you show how psychedelics could, in the predictive process in terms, update internal working models. But then you don't really continue by speculating about how that might be beneficial for mental health. So adaptive priors. And there's a lot of literature, rich literature on predictive processing, on stress, on depression, on how people who are depressed or anxious have an overinterpretation of their somatosensory or their interoceptive signals by focusing too much on every tiny detail that they observe in their body, etc. So how can the updating of the internal working models be adaptive and foster mental health in predictive processing terms?
Yeah, it's a good question. That is something we go into in the theoretical piece, as well as a companion neuroscience focused paper that's not included in the CAPA but is referred to in the other publications. In terms of writing the CAPA itself, it's at least in the context, in this context, I wondered whether it was too distracting to the reader to go too in depth at the beginning before, whether it was too much. But yeah, absolutely. I think there's a lot of work to be done in psychedelics about metacognition. How do I, right? Even if I have certain attachment priors, how do I relate to those priors, right? I might have within what I was saying before about acceptance commitment therapy, right? I might have specific priors and interpretation biases, attentional biases, right, that are known to be associated with depression, anxiety, social anxiety. I can still, whether psychedelics actually change the prior or allow me to have a different relationship with those sort of with those biases that I have, right, that I can recognize that bias and yet have a difference, take a different perspective.
But it seems you have a very high level interpretation of internal working models in attachment, as like high level beliefs about I'm safe or I'm secure, etc. But I wondered if, from a predictive processing point of view, you could also receive internal working models as embodied experiences shaped through like positive encounters.
Sure.
And that through embodied practices, such as, for instance, breathing exercises or also psychedelic experiences, those priors can be updated in an embodied way and actually can make you feel, make you feel secure. And then therapeutic touch might come into play. What is the role of that in fostering safe attachment?
Yeah, it's a really good question. There is a fierce debate that I'm not sure I wanted to make enemies of, now about a fierce debate about what exactly internal working models are. And probably
what is that debate about?
Is the internal working model in the room with us right now? Because if it's entirely embodied, right? If it's just an interoceptive account of sensory experiences that I've had, then that limits the extent to which they can be, I guess, top down, changed. But there's I would say that the social, affective neuroscience about attachment is relatively new, and so I didn't want to, go over my skis, as it were. But absolutely, attachment models are, about the way that we encode relational experience is very embodied right from infancy until adulthood, and I would welcome the opportunity to be able to explore that. Right, we talked earlier about triangulating data and pre-post, trade and state, and so that would have to be a part of a more robust study.
Yeah, I think so as well. Related to this, corrective experiences in psychedelics are key to update internal working models. And it is very logical then to think about these corrective experiences as prediction error mechanisms, right? That result in updating the internal working model. But how can a psychedelic experience be corrective if they are already shaped by internal working models in the first place, as attachment as a predictor of the psychedelic experience? And the observation that psychedelics act as non-specific amplifiers. So if you have an implicit internal working model that is becoming salient in the moment, how can that result in a corrective experience? Because that would just amplify the already latent internal working model.
Yeah, that's a really good question. It is a bit of a paradox because, my attachment models are going to shape my, the degree to which I'm anxious about a psychedelic experience ahead of time and well prepared with, the ability and resources to navigate it. One of the paradoxes about attachment is that the attachment system is activated by distress, right? And so you have the normative main effect of attachment being that when anyone is in distress, the attachment system is triggered, and yet at the same time, you have the individual differences of how the distress is coped with or is experienced, right? Do I experience the distress, in a sort of a clean way, or is my experience of distress also, affected by my own preoccupations of self-worth, in vivo? I think, about your last question about mental models, I guess the assumption that we would like to, test is that when, the same way that the psychedelics don't while they're a non-specific amplifier, because at the same time the prediction models are, loosened, so it might not be an amplifier of the individual differences of attachment, but an amplifier of the salience of attachments, right? The amplifier of the attachment dynamics that are ongoing in the psychedelic setting rather than my priors that I come with me. But it's sort of like when you fly and you drop off your baggage and then you come and pick it up. And so, as a very rough analogy for what might be happening is that, the baggage, as it were, that I'm coming to the psychedelic experience is very relevant to my functioning up and until And then, depending on the dose, depending on the facilitator relationship, depending on the phenomenology, I am having an experience that I'm not usually privy to because of my dispositional attachment, because of my habitual attachment priors. And then at some point when the effects wear off, it's possible that I might just pick up the luggage, at the arrivals gate, or I might be able to, make some marginal change in how in those models right after. But, probably more likely is that, I come back after the acute effects, and then there's, whether it's because of neuroplasticity or, because I'm psychologically made aware of different things, that then I have the opportunity to consciously rework those models. I think it's really important to look at, to what extent those models can be shaped by, conscious or non-conscious processes. But that's the rough analogy that
It's a nice metaphor, I think. I would like to also move towards the end of the questions I had, and again take a step back and ask you about to what extent you think that psychedelic therapy is exceptional or not compared to conventional therapy forms. I'm curious about your stance on this.
Yeah. I think that it's certainly novel, and I think we tend to perceive novel things as exceptional. But I think that it's even if it's sort of even as a novel treatment, we still know how people change over time in their feelings and their thoughts. And so, when you say exceptional, the association, what I hear when people say exceptional is that it's sort of a new category and it changes people in a way that other types of experiences don't. Whereas I tend to more, if psychedelics have therapeutic benefits, it's because it's, maybe a catalyst for things we already know about psychological change. I think that it's sometimes it's helpful when people talk about how exceptional it is, because I think it really clinicians and policymakers should really be called upon to critically examine whether the competencies that psychotherapists are already trained in need to be adapted in these contexts. So sometimes that the novelty of something is helpful just in terms of calling attention to the differences. But I think that you talked about also the natural high of runners and dancing and all these things. There's sort of altered types of experiences that can be used as a grist for the therapeutic mill, as it were. And I think that it's helpful from a research standpoint because it means we don't need to, pour all of the resources into developing new, skills for slightly different phenomenological aspects of phenomenology. And we can also better tie them into things that are actionable, right? We talked about, the runner's high being something that a patient can have agency towards and replicate for themselves, right? So if a person, this is a challenge we're encountering now in the ketamine-assisted psychotherapy clinic, is that, what do patients then continue to when they feel that, I can only experience X, Y, Z under the influence of ketamine and then can't replicate it for myself, and I can't, there's a great discussion about I mentioned earlier the debate about what internal working models are, and there's a paper that explores that in sort of operant conditioning terms, where my prediction errors for the support that I can expect in a certain situation is more in line with security, right? So that's how I would like to envision the effects of psychedelics, not as a new category, but as a catalyst of these changes, whether they're behavioral habits or expectancies between situations and supportive responses,
Yeah. So if you follow that line of thought, and also in your presentation, given the importance of development for attachment and especially early childhood experiences, what are your thoughts on the accessibility of psychedelic therapy for children or adolescents? So if it's not exceptional, maybe it should also be allowed as other mainstream therapists for children, because they are in a developmentally sensitive state, and you can actually target processes that might go already treated early enough.
This is something Rick Doblin has spoken about at conferences. He says, we want the world to be a net zero trauma, and if we assume that trauma is best treated as close to the event as possible, right, in a neuroplastic state when adolescents are in a more sensitive period. I'll confess to, after hearing him at conferences say these things, doing some investigative journalism and emailing maps about, I'm such and such a psychologist I would be highly interested in being a part of these studies. I would want to caution about people, experiencing psychedelics before the brain is fully developed, especially because of what you said about people having maladaptive narratives about what the insights are, right? Especially because, and I think you said children, right? I think adolescents might tend to, take the insights very intensely and seek to apply them in unhealthy ways. I think, especially with trauma, this is a unique challenge because this is something that over the last 2 years that we're, encountering in Israel in the war context, is that when a person is still sort of in the experience of acute traumatic stress, the treatment has to be different than when it is post-trauma, right? And so, whether the most effective treatment in the acute stage is more sort of cognitive, managing, practical, and it's too acute to do the sort of narrative reconstruction, and that might be part of post-traumatic stress. And so I would be wary about whatever the age of a patient doing a psychedelic trip too soon after a crisis. Exponentially more when the individual is in the sensitive developmental period and doesn't necessarily have the metacognitive abilities that make it more likely that the insights are more actionable and adaptive. I'll share that. I don't think I wrote this in the introduction, but part of my introduction to psychology was a health event that I had during my BA in psychology, where I was in a week-long coma at the age of 21 after a heat stroke. And so I awoke from that experience, with a very clear insight that I then tried in the years following to, shape my life, that ultimately I, found a lot of tension with integrating that in ways that just weren't feasible. And I remember the difficulty of trying to not, to not abandon the euphoric and resource activating elements of that experience, right? Because that really did. But not being taken over the edge of a cliff by those euphoric elements. And that's, for me, I've since had some, self-experience in clinical training environments with psychedelics. But I even still use that experience, that health experience, as a very instructive paradigm for how I talk about psychedelics.
Yeah, that's a very nuanced answer to the topic. Maybe as a final question, and still on the topic of psychedelic exceptionalism, couldn't it still be the case that psychedelics are exceptional due to their potential to increase suggestibility, boost placebo effects, trigger experiences that you would not normally encounter, but also with respect to informed consent, that people cannot predict the consequences of undergoing a psychedelic experience and don't know actually what they're consenting for, or also in terms of therapeutic touch. So a sober person might say, well, I don't want to be touched in a session, but might revoke that sober decision while in the psychedelic state.
Sure.
So in that sense, it raises dilemmas that we don't see in other therapeutic frameworks.
Anything is possible, and until your last sentence, I might have signed on to everything. I think that, power dynamics are always something that training therapists are educated in and touch and consent. And even though traditional psychotherapy or standard psychotherapy, I should say, doesn't have the sort of transformational experience that psychedelics can induce, when you sign up to therapy, you may have a particular goal in mind, but that goal is also shaped by the pathology that brought you there, right? And so the goal also might be changed throughout. And so when you consent to psychotherapy, even without mind-altering drugs, you're basically consenting to something you don't know the exact nature of. Actually, one of my supervisors used a concept from Jewish law, a guarantor, right? That the therapist is sort of viewed as I have to trust I maintain my partial autonomy as the patient, and if something is not comfortable for me, then I have absolute right to whatever to stop the process. But I should also recognize that I'm putting a lot of trust in the therapist and in giving them a certain amount of discretion about maybe the therapist isn't going to tell me what to do, but I'm coming to them for their clinical insights, right? And you're absolutely right that in psychedelic contexts, there are new risks, or the risks are intensified. But Freud talked about erotic transference and countertransference. And so while these challenges have new form in psychedelic settings, I don't know if they're exceptional. We need to do the work of really spelling out what are those novel presentations and what are the challenges and how should we do it. But I stop short of saying that it's a new category that we're not already aware of.
Yeah, interesting perspective. Thanks. I would like to give the floor actually to the committee, assessment committee, or to the chair.
Thank you very much for your question. Yeah.
Yes. Thank you very much for this interesting discussion. So now it's the turn for the examination committee. And I start with Professor Cherniak, who has been traveling the longest distance to have years.
Thank you, and thank you for your work, and thank you for a thorough opponent discussion here. I've been watching you during this, and in the background seeing this imagery, and I was wondering if you had some comment on what it stands for.
Yes, absolutely. Thank you. First of all, it's a piece by my wife's aunt. It's an artist who's designed a lot of public installations in New York City and elsewhere in North America. For me, it's sort of, her name is Nancy Bloom. She has a great website. I encourage you to check it out. For me, it's called Clouds. But to me, they sort of look a little bit like brains. But also it's sort of the connection between this cloud and this cloud, for me, exemplifies the sort of intersubjectivity of therapy, of interpersonal relationships, of psychedelics, where each individual, right, the facilitator, the participant, the therapist, the patient, whoever, are experiencing their own complex mix of reality and fantasy, as well as the interpersonal space, between my subjectivity and the other's subjectivity.
Yes. I thought those terms, it's been playing out between the two of you and then Anyway,
Yeah.
I wanted to frame a few questions. I have many questions, but I'll try to limit them. And one that I wanted to point out is to speak to your metacognition and potential biases in this work. And one is more from a feminist perspective, in the way God is used as a male entity, and what implications that have, and what a potential reframe could look like.
Sure. Yeah, that's a really.
I miss the goddess in this work.
So
And also the fact that there are six men as authors for the proposal, if that has in any way impacted? What are your thoughts?
I think it's a really important question, and I think especially when we're talking about intersubjectivity, getting a rich, varied chorus of voices is really important. It happens to be that both of my supervisors are male, and we co-authored with Robin Carr-Harris, who's a major figure who also happens to be male. I think it's a general problem in psychedelics as well. In the paper, we take efforts to spell out that when we talk about God, we're referring to supernatural entities as they're constructed in the cultural context. I'll add that from a Jewish perspective, God is beyond gender. And so we talk about God in both male and female perspectives. Even in English, there's no really parallel for that. Even within that, there's an interesting conversation to be had because the different attributes of God are gendered different ways. And so, the female or the divine presence is conceptualized as female.
Exactly.
Yeah, so I think that's a really, really important thing. One of the studies that, I think, there's a discussion in psychedelics as well as the general science of spirituality is how much are these experiences sort of perennialistic or sort of core mystical experiences or culture bound, including gender discussions and experiences. I think we have a ways to go in terms of informing how much spiritual experiences are culturally bound or sort of pure sort of light and unity experiences. I tend to fall on a sort of balanced position where both are true to a certain degree. I'm looking forward to addressing that. I have one of the studies that I did that because of PhD constraints I wasn't able to complete is I interviewed 70 Jewish psychedelic users about their experiences and their beliefs before and after. And even though we haven't really analyzed the data, that's one of the themes that comes out. Actually, this sort of more fluid interpretation of what God, is, or a greater recognition that God is beyond the boundaries that we usually tag onto him.
Or her.
Yes, in English. To however God is constructed, right?
Yeah.
Yes, I'm sorry for that.
This is important because also the patriarchal male authority figure can evoke internal working models for clients who are maybe women or
Yeah, absolutely. It's interesting because in attachment theory, the gender critique is somewhat opposite, where
exactly
the caregiver is assumed to be female, and only recently there's a discussion of the father's role and attachment related.
Exactly.
Yeah. So these are and nobody asked this yet, but the choice that we made in study 2 to aggregate the father-mother scores, was a necessity of constraining the statistical model, but I think is highly questionable. And I think you'd be interested, in attachment theory generally, there's a discussion of how the network of attachment relationships is organized, whether it's sort of hierarchically nested or there's sort of a more, bungalow type, network and which models are. So I think in future research, we should look at the relative contributions of father, we didn't even mention, gay or lesbian couples where there's not a father mother. So I think that's a really, parent 1, parent 2. I think actually in the survey, I allowed for that. But it's because we didn't get to the interviews yet, that hasn't really been, but it's important.
Thank you. So that leads me on to my next question, also regarding bias, because to me, you're referring here to attachment in a kind of dyadic way, and you were touching on it now when you replied. But I also wonder if that could sideline other spiritual paths, possibly, that don't neatly fit into that model of a dyadic attachment.
Yeah.
Comments.
So this was actually one of John Bowlby's regrets later. Because of the word attachment, so people started thinking about attachment only in terms of the dyad rather than what I think he originally intended, which is, these mental models of the relational world, which can be dyadic but are not restricted to one-on-one relationships. There is some research in terms of, you're asking about the attachment in religion and God. So I think there is some research about spirituality in Buddhist contexts. Their attachment obviously is a very different connotation. But again, I would reiterate that attachment is, while it's spoken about mostly dyadically, it's not restricted to that. And so we do need to be creative in terms of how we define it and express it in these non-traditional or non-typical situations. But I think it's still relevant insofar as it describes the way I myself interacts with the world outside.
Yeah, but I'm thinking that, from a Buddhist perspective,
Yeah.
or Mahamudra or Tantric, or even indigenous animist perspectives, maybe the dyadic attachment model would be seen as a negative prior.
Sure.
That would be in the way for oceanic boundlessness or merging with everything, or
Right. Even with the typical, in the Christian research, there's some research recently about how attachment representations of God interact with sort of experience of angels or demons or something, so even in that context, it's not necessarily dyadic. I think the studies that relate attachment to spirituality in the Buddhist context are taking this perspective that attachment is relevant to mindfulness and compassion and these intrapsychic resources that I bring to spiritual exercises rather than how I perceive sort of entities. So your question is a very spot on one.
And it's interesting to think about, and maybe, thinking about religion more inclusively, and global, what the human experience entails from different perspectives.
Yeah, absolutely.
I have one more question that I have to ask you about, because you refer to Nardo and Torun's work with rodents, animal models, and the critical theories of social reward learning. And obviously, that's a very interesting framing in terms of attachment, right?
Yeah.
Because when we are babies, that's when we have, before 18 months of age, that's when these patterns are being laid down in our brains. And then it's really hard to get at them, right? So she also suggests that that is not primarily mediated by the serotonin receptors in the brain, but rather downstream. She talks about extracellular matrix and gene expression and things that take time to lay down also in the brain. So she has this window. You show the pictures where the window is open.
Right.
How would you take care of that therapeutically? I'm thinking from a memory consolidation window, and we open this for 1 or 2 weeks after a session.
Yeah.
And how can we do the best out of that? And how can we also protect our clients from that perspective?
Such an important question. Yeah, it depends on the substance, obviously. But
the length depends on the substance. Sorry? But the length of the opening of the constellation window seems to be, but the mechanism is the same for all of them, whether they are the classic ones or MDMA or ketamine, which is also implying that it's a more downstream mechanism.
Sure.
Yeah.
Yeah. So, first of all, I want to couch this in what I said earlier, that that openness is, not exclusive to psychedelics. And so people, going to psychotherapy itself increases suggestibility and openness, and in ways that have been shown in studies of the neuroscientific effects of psychotherapy. However, I think, what you're saying is really important, and it's why in our clinic we instruct patients that the persisting effects can sometimes be even more meaningful than the acute effects, because depending on the substance, however long they're sort of more open, provides opportunities within their own emotional world to make those or experience those those changes, you're right that it makes them somewhat vulnerable, right?
Very vulnerable.
Yeah.
If they go home and become abused or something.
Yeah,
that's what will
exactly.
be reconsolidated when the brain is plastic.
Yeah.
I have a big concern regarding this.
Yeah, absolutely. In our clinic, we screen out patients without a sort of secure social network.
Nice.
And we allow them to stay in our integration room for, I mean, it's only, for until the end of business, even if their ketamine session is at 9 a.m. And we urge them to scaffold their day to, not just day, but, depending on the substance, an extended amount of time to, whether take off time from work or to, plan enriching activities or not to put so much pressure on themselves. You're absolutely right. I think that's one of the risks of psychotherapy. I think also psychotherapy generally can have, negative effects, right? Because you enter this space of vulnerability and you put your trust in someone and maybe, negative experiences happen. That's a little bit, right? In broad terms, that we increase the risk and also potential in psychedelic.
Thank you. One more thing.
Please.
Is it okay, or do we have to?
Absolutely. Yeah.
Okay. So last question is regarding how you best can screen. You say you look for social safety, and also the common factors. I'm thinking about things like dissociation, for instance, or if it's in psychodynamic terms, we talk about structure, internal structure. Are there some patients who might have mystical experiences? They're prone to those because of those preconditions.
Yeah.
And then, what you do is to create spiritual bypass loop.
Right.
Where people will have a instant relief, but then be much more vulnerable, and also to cult phenomena and all kinds of, la la land situations.
Sure.
So just about that screening. Are we doing that correctly within psychedelic psychotherapy?
Who's we? Like,
in our minds.
Yeah, I don't envision sort of that's sort of the spirit of proposal number one. Where if we know that people with divergent attachment models can have divergent experiences, then maybe we think more critically about whether to include them or not, or how to best support them with different ways. Or whether I think that
but should they even have classical psychedelics?
Right. I think I don't foresee attachment specifically being the criterion on which this is based, but I absolutely think that there should be some amount of screening, right? Whether it's history of traumatic dissociation or severe personality disorder, or even if they don't have a history of mental health diagnoses, but they have really maladaptive expectancies for the psychedelic, drugs shouldn't be introduced until the matrix is well supported, well ready for the soil is fertile for proper growth. Yeah, absolutely.
So I wonder if these things may explain why physical experience can induce more anxiety.
Yeah, absolutely, because they can be destabilizing.
It could be very destabilizing.
My own personal experience that I mentioned, my insight was, a religious oriented insight, and while for a week or two that was really euphoric, it set me up for some really destabilizing things later. And so I think that's something we have to be constantly mindful, even without psychedelics, how much more so when we're using mind altering substances, to be aware of, is this experience something that is related to motivated expectancies of the drug in a way that is counterproductive to therapeutic goals. That's the whole motivation behind the GCMQ, is that just because an experience is mystical doesn't mean it's therapeutic.
Exactly.
Yeah.
Thank you so much.
Thank you for the questions.
I don't know.
Osaka?
Yeah, sorry. No problem. Thank you for doing this really interesting work, and also for the discussion with the opponent. It's really a nice learning experience. I was also interested in this cloudy thing. I'm happy for your question. I prepared round two. But I will also start from quite beginning here. I think it's page 1,
Okay.
where you write.
In the beginning.
Yeah, to my beloved portraitures, past, present, and future.
Yeah.
I am a better man for the knowing of you. And I looked this up, and portraitures should be like people who are carrying a kayak or a boat between two lakes or two
Yeah.
waters. And I was wondering, is this between psychology and theology, or what is this?
So this is actually how I view my origin story in psychedelic field. I'm a proud Canadian. My first canoe trip was in utero. So my family and I, we would go on canoe trips nearly every year, if not every year. That was my first introduction to awe-inspiring experiences. My father passed away during the PhD, and he was a canoe tripper, and there were rules that when you got to the campsite, what you would do first, and they were mostly pragmatic, set up the tent before you get the food. But even before all of that, you go to the highest point of the campsite and look at the horizon, the kind of thing. So, portage is when you carry the canoe from one river to the next. And, I think it's also really valuable framing for psychedelic experiences, right? When you go on an awe-inducing experience, and you also have, right, having an awe-inspiring experience doesn't exempt you from certain responsibilities or ethical codes and your obligations to those you're on the trip with, right? Yeah. Thank you for the question.
Yeah, thank you.
Yeah.
So I thought also that it might relate to my main question, actually, because I think your dissertation describes God and other spiritual figures in terms of attachment processes and psychological functions and culturally scaffolded phenomenology. And you treat these experiences as internal representations rather than external agents. But you wrote that you're also a rabbi, and I was thinking, how do you reflect on the relationship between this psychological model and your own theological understanding of God? In what way do you see them as compatible, complementary, or maybe fundamentally different? And how do you navigate the tension between studying like divine experience as psychological phenomena and holding religious beliefs maybe in an interdimensional relational God?
Yeah, it's a good question. At the risk of a sweeping answer, my initial interest, people usually assume my interest as a rabbi in psychedelics is for the phenomenology, for the spiritual experience. Actually, the origin of this interest was about medical ethics, which Judaism has, a lot to say about. I think that, at least from a Jewish standpoint, I think we're the only religion that really claims a revelation en masse. Notwithstanding individual prophets and so the Bible, the Hebrew Bible says that even if someone comes and is able to produce miracles and make prophecies, if their miracles or if their teachings violate sort of the communal revelation, then we shouldn't follow them, even if the miracle is demonstrable and replicable, right? And so I think this really calls us as researchers and as clinicians to, however sexy and exotic the subjective effects of psychedelic trips are, is to always have a foot or be checking ourselves that we're using frameworks that are reliable and ethical and you know what I mean?
And my follow-up question here, it's maybe really naive, but also really interesting that do you think that psychedelic use facilitates the work of God?
Facilitates the work of God? What do you mean?
Yeah, because if you believe in an interventional relational God, and then you explain everything with neuroscience and psychology things, is there a space for
Oh
Do
my
we
gosh.
help God
So we don't
by
have-
taking those?
So we don't have time for me to give a scoping class in the fierce debate in Judaism about to what extent God is interventional. I think that the loudest voice in that raucous debate would say that we only understand God's intervention in hindsight. You shall not see my face, but the back. Looking back. In terms of a neuroscience, the neuroscience of religion, I don't know if I tried to follow the footsteps of my rabbi, from a Jamesian perspective, to sort of say that Hare is my rabbi in this regard, that the neural substrates are underpinnings of spiritual experience, to what extent that the cause or reflection of these, we don't know the roots, but we can examine the fruits of these things. If we want to take a biological reductionistic perspective, that's certainly people's prerogative. I think I've wandered a little bit, but I think it's an important question. What does God want us? Are we doing what are we doing from a religious standpoint? I can't speak for other religions, but I can say from a Jewish standpoint that I don't think we're necessarily we can take a psychedelic and experience God in an idolatrous way, the same as in waking consciousness, right? Even under the influence of a psychedelic, we're still experiencing God as we construct him, her. And so there's a great book on Moshe, what's his name, Moses, on a sort of a religious objects relation theory that in his epilogue quotes from a play, something about the life of Anna or something. But in other words, that God in any state of consciousness is embedded in how I'm constructing God. And so from a Jewish perspective, we put so much emphasis on sort of a negative theology. We can't say anything about what God is, but we can't say what God isn't. And sort of it's so when I take a psychedelic, I'm not encountering God on God's terms. I'm still encountering my own projection of what God is or isn't. And yeah, I don't.
I think you did it really well. I think it's a really strange question, maybe also. But
No,
my last one is also because when I read page 37, it was my understanding. It was really a positive depiction of God, and I directly thought about like Christopher Hitchens and Daniel Dennett, and
Sure.
what would they say about this? And they might actually argue that your psychological framework unintentionally strengthens the atheist claim that God is a human construction and involved internal model for coping with fear, dependence, and uncertainty. I really read them also. They might say that your findings support religion as a comforting illusion rather than a relationship with the actual being.
Yeah.
What do you think about that?
I think that it's certainly possible to come away with that inference. I would say that religion and spirituality serve multiple functions. Sometimes religion and spirituality demand of us things that are not good, that don't feel good in the short term, right? And so religion, sometimes in an evolutionary perspective, we might say that the short-term pain is ultimately, good as well. I'm not bothered by that theologically, because ultimately to be able to understand God within my own brain, I need to latch onto something, and even as it's interesting because some of my rabbis have given me the opposite critique. God might serve a certain function, but that doesn't mean that my altar, turns into is limited by that.
Yeah, thank you so much. And I just, my last reflection is also that I don't have used psychedelics, but I read a lot and I do research on it. And like reading your pieces, an additional like intervention that really enlarges my understanding of it. And it's also like a therapeutic thing for to just read about it.
Yeah, I think so too.
Thank you so much.
Thank you. Thank you for saying that.
Thank you. And Associate Professor Emanuela Smith from Stockholm.
Yeah, thank you very much. Thank you very much for this presentation and discussion. It was very illuminating for me. I learned so many things because I don't come from this field of study. So I have a couple of very short questions that are both ignorant and naive, also for that. But because I come from the history of religions, actually, I'm not going to ask you about God. Because I can understand more or less.
Please.
But I'm going to ask you about believers or non-believers. And I was a bit wondering, because you mentioned in your research that you worked with Jews. It's a general category I had the feeling, if I understood you, or if I understood your research well. And I was wondering in which degree religiosity of your research participants played a role. I mean, were they observant, were not very observant, and how this might have affected their own experiences?
Sure. Yes. So it's a good question. There's a joke that for every two Jews, there's three opinions, right? So the sample of the study, notwithstanding only being within a Jewish context, has a lot of heterogeneity. I don't know if I told you, the first participant I interviewed was a trans convert to humanistic Judaism from Catholicism who had converted in the last year. Right. So to what extent can you call that a Jewish psychedelic experience? Right. So just to give you an idea, and I've had these conversations with David Yaden about just because you have two Jews, it doesn't mean they're having the same experience. And so we'll have to grapple with those challenges when we get into the interviews. I think my perspective certainly informed the questions that I posed, right? I'm interested in the not only the changes in metaphysical beliefs, but also ritualistic behaviors that are changed, or either in whether people adopted new practices or left practices, but also the subjective experience of the same practice. It's fascinating. It's a very important question. I'm looking forward to being able to shed more light on that. Yeah,
that would be great. And the second question, I mean, it is a really very general question, but you work a lot with mystical experiences or religious, spiritual. You describe them differently. I don't know if you also make this distinction actually in the research, or you just use now interchangeable categories. And I've been wondering if you think that there's a difference if I have a mystical experience using psychedelic what's called substance or not.
Yeah, that's a really important question. Mystical experiences were studied before psychedelics were studied, right? Whether a person reported having a mystical experience in their life. The term mystical, spiritual, religious, it's a controversy in the field because the main scale for studying these types of experiences, or not main, the most widely used, I don't think it's the best, but it's called the Mystical Experience Questionnaire. There have been a lot of critiques about it because it only registers positively valenced, for example, or privileges experiences of unity, whereas mystical experiences might be different, especially in other cultural contexts. I think sometimes people use the term transcendent experiences. There's a recent paper by Roman Politsky and his colleagues at Emory University about a framework for what's the acronym SERTS, Spiritual, Existential, Religious, Theological, trying to from a clinical perspective, how do we relate to all of them, and how can we best prepare our patients for those things? It's sort of hard because the analysis of these experiences is totally dependent upon how people report them, and that's dependent upon the words that they use, which could have a religious interpretation or not, depending on whether you're the participant or the researcher, right? And they can have a dynamic, right? If a person has a intense spiritual experience that then makes them convert or leave religion, then it can have a different interpretation even in the same person. Right? And this is some of the work that we did in parallel with my dissertation work about religious changes among psychedelic users. It's certainly a valuable question, and sometimes it's an important one because sometimes researchers have these biases that aren't spoken out loud when they use mystical or religious or. So thank you for the question.
Is the kavana also important? So if I want to have a mystical experience, and I pray and I fast, or I just take psychedelic habits, is there a difference there? I mean, I'm really curious about that.
That's a really
if you're curious too, you could put the research ground together.
I would love to. I think the intention is mostly studied in a clinical frame. Like what is the therapeutic effect of having a certain intention, whether it's spiritual or not. I don't know if people have studied spiritual aspects of as an outcome. That's certainly some things that I'm looking forward to delving into in the study that we did. But I would tend to speculate that anything, whether it's the environment or the individual's intention that is making something more psychologically salient, is likely to relate to the experience that they have and potential outcomes, right? That's, yeah. Thank you.
Robert, you Associate Professor Robert Boss.
Thank you. Thank you very much for your discussion and presentation and your wonderful thesis. And I only have one question. And I would like to just ask something about this integration between attachment theory and predictive processing. Do you think that there's or maybe I can ask like this. Do you understand what I mean when I say that I can perceive some type of mismatch between levels? It sounds so good all the time when we refer to this, oh, that's a prior, oh, my prior. But it really comes from this, traditional, let's call it these brain-based models and so on. While attachment theory, from my perspective, I'm not an expert there, seems to operate on another description level.
What do you mean on another description level?
Like we don't talk about brains there. We talk about, experiences and things like that.
Yeah.
So I'm just curious, do you see any potential mismatch between levels there, between attachment theory and predictive processing?
Yeah, I think that's a really important question. In the attachment literature, we talk about different levels of representation of attachment models, explicit and implicit. Michiel, you mentioned your paper about the different levels of mechanisms in psychedelics, whether pharmacological and psychological. Again, the neuroscientific research of attachment is relatively new, but I think that's one of the strengths of attachment theory, and one of the reasons that I chose to integrate it is because it has, on the one hand, very experienced near language, and people, when you talk about safety and support, people and vulnerability, people know what you're talking about. But it also has, it is very, there are demonstrated representations in the brain of what those feelings look like. Not trying to claim that attachment theory is all inclusive in this grand scientific theory, but it does allow us to, and it's something we should do as a field, to look at how these different levels of mechanisms interact or differentially predict.
And I have asked this to Per too. Do you think that one can see I assume we agree that the predictive processing framework is a very general framework, right?
Yeah.
Do you think that one can see attachment theory as like almost like an instantiation of that? That on the other hand, the predictive processes framework is a generalization of the attachment theory?
Is a generalization. Well, I know that predictive processing has been, criticized for being over generalized, and so I hesitate when answering this. But I do think that is exactly what we're trying to get. We go into more detail in the chapter in Michiel's handbook when we talk about the neurobiological mechanisms. But attachment models are both experientially informed, but also predicting. And so there is, just like in predictive models, there's this active inference where I'm using the models that are shaped by my past experiences, but I'm also, predicting at the same time. And then, my behavior as a child of seeking proximity to a parent is my active inference. I'm not testing, but I'm observing the responses to it.
So sorry to interrupt you. That's the type of jump that I have a reaction to. That we start to, whatever is happening here, it's an active inference.
Yeah.
Do you think that those jumps between levels have an appropriate place in science?
It's a good question. I should be disciplined about when I'm to be
Everybody
explicit about which level I'm on. At this end, I think it is important to try to, whether conceptually or empirically, see how these constructs, relate to one another. And dual process models is one way we can do that. When we are sort of linking declared beliefs and self-report with with reaction times and implicit attitudes, and whether that's the trend, or a trend now in neuroscience. I'm not a neuroscientist, but something that I observe is a trend towards finding behavioral correlates for fMRI results. Even though those are different levels, we want to know what when we see this thing in the brain, what is it linked to on an experiential behavior?
Yeah, that's a challenge, and I'm just pointing to maybe there is a challenge there.
Absolutely.
Yeah. So thank you very much.
Thank you very much.
Thank you. And now it's time for the audience to ask the questions you have been thinking of for your whole life to Aron. So please. Yes. Anyone wants to ask a question? Okay.
Maybe online.
In Jewish law, there's a construct known as silence is viewed as agreement. So I don't want to interpret the silence that way, because I imagine there's some. But
I think there's a lot of agreement out there, and I also think it has been a really wonderful. I have enjoyed the discussion between the two of you and all the questions from the examination committee. And the audience, of course. Thank you to all of you who have been here today.